Siwrna i chi gyd a croeso I bwrs iechyd Prifysgol Nair and Bevan. Good morning, everybody. I'm sorry to start this meeting slightly late, but I've just had a meeting with the Minister, in which I will report later. So we are slightly late into that. Thanks. I welcome the guests that are attending today. Nice to see you. And today's meeting will be recorded and published on the Health Board's website for viewing following the conclusion of the meeting. We have a number of apologies for absence: Martin Blencherer, Richard Clark, Phil Robson and Peter Carr. Tracy Daskovich will be slightly late, as will David, who will be joining on Teams. However, before we start this morning, I think we should pause to reflect on the consequences for people in Gwent of the dreadful contaminated blood scan. I believe apologies are insufficient, and although compensation is now to be paid, this cannot recompense for the pain and suffering of those affected, whom we all remember. So thank you. Declarations of interest for noting for any of the items on the agenda? No?
Yeah,
Louise.
On the one when we talk in about the MS,
Yes.
definitely John, I won't between interest with that.
Fine. All right. Thanks, Louise. Okay. The draft minutes of the Health Board meeting, firstly on the 27th of March. Are these a correct record?
Yes.
Yes, thank you. 10th of April. Probably. Ewan?
Yeah. Excuse me, my voice has gone completely. Yeah, it's just one of the actions. I just noticed one of the actions hasn't been taken across into the action log.
Okay.
270310.
70310. Yeah, we'll pick that up. Thank you, Ewan. 10th of April, otherwise, okay, with that amendment into the action log. Thank you. The board action log for review then, Ron, please.
Thanks, Chair. So the version presented includes 5 actions, 4 of which are marked complete and 1 not yet due in relation to CAM's performance, and that is scheduled to come back to the board in July.
Thank you. Any queries, any questions on the 2 sets of minutes? No. 1.6, report on sealed documents and chairs actions, Rani.
Thanks, Chair. So this summarises the use of the Health Board's Common Seal and the use of Chair's action between the period 5th of March and the 30th of April. The seal has been carried 3 times and the detail is outlined in the paper, and 4 decisions have been taken by the Chair on behalf of the board in this period, and again the detail is summarised in the paper. The board is therefore asked to ratify the use of the seal and the decisions taken by the Chair on behalf of. Thank you.
Thank you. Any questions to Rani on that? Then, thank you. 1.8. 1.8. Report from the Chair. Apart from my usual meetings and my visits, I've done a number of additional things over the last 2 months. The NHS chairs had a meeting last month, and we have another one next week, at which we discussed the financial position and the reorganisation of services that may be necessary as a consequence of change. We have agreed, as have the chief executives, that we will keep each other very, very closely aligned, because it would be quite wrong for the decisions taken by one board to affect the population of another health board, so that we will keep very closely aligned. There is no doubt that everybody really is struggling, and we're working very closely together, particularly in the South East, to try and work better together to secure improved services for our populations. We had a national commissioning review, as you know, where EASC and WISC have now joined to become the joint committee, which is a subcommittee of the health boards. It had a fairly energising start with having to consider the EMERTS proposals. But nevertheless, we are devising at the moment a way in which we will be able to hold to account more effectively than we were able to hold to account the previous organisations, to ensure that we are totally aligned in the commissioning of comprehensive services for our population. And so that's going on. I have finally finished the Ministerial Advisory Group report, which has gone in to the Minister, and I await to hear what she wishes to do with it. I undertook 2 visits with the leader of Monmouthshire over the last month, to Neville Hall and to Chepstow. She was very keen to see the integrated work that was being undertaken in those 2 areas. I was very pleased with the progress that had been made, and particularly the new digitally enabled facilities in Chepstow to assess people better, more appropriately, particularly as that now is a very much a community orientated service. And I think that Marianne appreciated the visits very much. I obviously took her to see the RAC in Neville Hall so that there would be a full appreciation of the scale of the issues that we were facing. And as you all know, we will be having a report on that to our July meeting. We've also had a number of meetings with the chairs and the leads of the RPBs in terms of partnership working. There is a draft consultation document out at the moment in terms of changing both the scope and the terms of reference of the regional partnership boards, which will be discussed next week at our regional partnership board. There are some areas where we think a further look might be useful in terms of effective partnership, and also to underline the fact that this is a partnership, it is not a statutory body, and therefore you have to operate in a very, very different way to gain the results that we need. And we will be reinforcing that in our response to the government. We've had a meeting of the Public Services Board where progress was reported on the implementation of the Marmot standards. They are very, very closely aligned now with the work both of the PSB and the Regional Partnership Board. There's quite a lot of cross relationships there. So I have arranged to meet the chair of the Public Service Board to ensure that our agendas are aligned and not overlapping and crossing each other. I've started the performance reviews of the independent members. I do hope you've all put your forms in. And hope, well, I've only had Ewan so far, and he looks as if he's almost survived it, although he's got a cough. But I've also met with the special advisor, the new special advisor to the Cabinet Secretary, the chair of the vice chairs, the chief executive of the Health Inspectorate for Wales. Obviously, the chair of the chief executives group, we have to be very closely aligned, and the Gwent Council leaders as well. I've just had a meeting with the Minister about performance, which I will advise you of later in this meeting. But this is a new suite of meetings that she has established to ensure that we are driving the priorities that she has provided to us in our objectives, which we received yesterday. And those meetings will take place monthly to be aligned with the meetings of the chief executives with the Director General. We are really into a great deal of detail, helpfully being conducted. But nevertheless, this is an escalation of the escalation framework that has just been published by the Welsh Government. And as we're in an escalation category, then the scrutiny will be intensified, as it has been in this board. So it's been quite busy, really. Are there any questions? No, thank you. The Chief Executive's work longer than mine.
No, thank you, Chair. So just two quick things before I kind of go in. So and thank you, Chair, for raising the infected blood inquiry. I just wanted to add that as Chief Executives working with Welsh Government, we will absolutely be considering those recommendations and agree with the next steps. And just to say, firstly, my heart goes out to those families affected, and we will do all we can, as you said, to support those people affected in our local communities. So really important just to emphasise that. I also wanted to pick up the fact that the BMA has suspended the industrial action since we last met, and hoping, progressing with talks with Welsh Government. So hopefully we'll make positive progress on that, given the disruption and the work we plan to do, and recognising the staff involved in the industrial action. So I just wanted to highlight that positive progress, and we are hopeful that a resolution will be achieved. I wanted to focus a little bit then on 23-24. So the last few months we've spent a lot of time kind of finalising last financial year, and we've been meeting with all of the divisions across the Health Board, which we do as part of an end of year review, which is a really good opportunity to look back and recognise all the positive progress that's been made, but acknowledge the challenges and the priorities going into 24-25. And we've also done that ourselves with Welsh Government, because we had our joint executive team meeting, the JET, with Welsh Government 2 weeks ago, which is that look back and look forward. So I just wanted to draw out some of the headlines that have come out of that process, but I think it's a really good opportunity to kind of do that 12-month look back and realise what we have achieved and the challenges we still have going forward. So firstly, in terms of workforce, really good progress around recruitment and retention, and the progress in the people plan. We've reduced our turnover, we've increased the number of substantive staff who are working in our organisation and reduced our reliance on variable pay, albeit there's still a high reliance. And we've delivered an £18 million reduction in our agency staffing, which really does help us progress to that sustainable team ethos that we're working towards. Linked to that around finance, we started the year with a 112 million deficit last year, which was heading up to 156 million. Really grateful from Welsh Government around the funding and the work we've done as a Health Board to reduce that level of deficit down to 49 and hitting that forecast, albeit we know we are far away from the control total. We've got a lot more to do. But we did deliver a record savings level of 43 million, was the highest level of savings that any Health Board delivered last year as well. Quality and safety, completely refreshed our quality strategy on the back of the duty of quality, the duty of candour. Lots of work by the clinical executives on this, and the quality improvement has become much more kind of reinvigorated across the organisation, with a lot of key programmes of work happening around that. And learning from deaths report, which has been really helpful, which I'll pick up briefly later. Patient experience has been a huge focus. We've introduced the patient advice liaison service to help people with complaints, and our bereavement offer, which I know we're going to pick up in the patient story, is a key priority for us. Also that communication with patients during the complaints process, and we're trying to really get on top of those old complaints. Performance, this is a key priority for us. We've got areas of good progress, areas of further work, but we have spent the year reducing the backlogs in a number of areas, particularly cancer, diagnostics, planned care. We've now got 30 of 36 specialties, removing all those long waiters, but I'll come on to, we've got 6 specialties that we are struggling with, and likewise mental health, reducing the backlogs. The estate, we've made good progress. We've got a new breast unit, a new endoscopy unit, and we opened the Tredegar Health and Wellbeing Centre, the Bevan Health and Wellbeing Centre. So, and we're already seeing the benefits around cancer weights and part of our primary community care plan for Tredegar. And around primary care, when you look at the data from the whole year, we've increased our offer around pharmacy, optometry, dental access, and our overall appointments from GPs is increasing, albeit we know there are still significant challenges on the back of demand. And 5 GP practices that were being managed by us are now being put back into independent contractor status, which hopefully will improve the access for the patients in those areas, and also introduce 111 Press 2 for mental health, which we know is a key priority for us. Prevention, the work Tracy's led around the joint strategic needs assessment has given us much more clarity around the priorities going forward, and we've relaunched our diabetes and cardiovascular prevention programmes. and we have relaunched a staff communication and engagement process as well, and we'll come on to comms and engagements later. So last bit of highlights, notwithstanding the challenges that we know we are facing, acuity and demand continues to grow. If you look at some of the data, some of it's in the reports later, 20% increase in referrals for planned care, 30% increases in cancer. The cancer referrals last year, 6,000 referred, 12,000 more than pre-COVID, you know, huge numbers. We're seeing that as well in mental health services, children's services. So that's something we really, and across the urgent and emergency care service, and particularly around acuity. Urgent and emergency care continues to be an Achilles heel for us, despite the significant amount of efforts that is happening across the system and with our partners. We are seeing signs of improvement, but sustaining them is a key challenge for us. And we pick that up later into 6 goals. Mental health performance and the workforce challenges there is something we're continuing to work on. And planned care, as I mentioned, there's 6 specialties in 3 in particular that we are struggling to get that backlog and that sustained performance with long waits for patients in those specialties. We'll pick that up under the planned care agenda. Our estate presents us challenges, as we know, with the RAC issue in Neville Hall and places like St Willows, where we've got plans to try to address those in the coming year. And likewise digital, with the challenges we've got around the need for a lot of good progress being made, but we know there's lots more to do. And as for finance, we know the financial context we are working in continues to be a huge challenge for us, with another ambitious savings plan and a need to get that kind of route to sustainability is a priority. So they really are informing our priorities for 24-25. We've had some feedback from Welsh Government on our annual plan, with areas where further progress, as mentioned, as the chair referenced. There were new KPIs issued last week across the main priority areas of urgent emergency care, planned care, diagnostics, cancer, mental health, where there are new trajectories and new targets, and we are required to submit our response to those next week to Welsh Government, and also a need for us to review our financial position and whether further improvement can be made. And we pick those up as part of the discussions later on. So whilst all that's going on, we continue to try to keep strategic as well. You can see the leaflet on the table around the work we do around our local strategy. We've been, as Chair mentioned, doing some work with the RPB and the PSB in terms of how we can strengthen our partnership arrangements. And there's also been a Team Wales event, and we had a focus on a healthier Wales, which Welsh Government are looking to refresh as well. So just to finish, we've shortlisted, we had the staff recognition awards, a huge number. I don't know if I mentioned it last time, 760 applications. It was a record number. It was the hardest task to try to shortlist and then select winners, which we've done through a very robust democratic process. And we have been letting people know those who have been shortlisted to the awards event. And within there was 400 awards nominations from members, from patients who have pulled out individuals who they feel have gone over and above and beyond in the and they really are a true testament to the hard work, and they will just be a flavour of what is happening across the organisation. So I just want to thank everybody for their continued hard work in a very challenging context that we're looking in. Thank you, Chair.
Thank you, Nicola. Any comments, questions, Louise?
Yeah, thank you for that, Nicola. I'm just wondering, have we got a date for when we'll be going to public consultation for the stroke reconfigurations that we've done in an emergency setting?
Yeah. I don't think we've actually finalised the date yet.
We are, yeah. So we are having conversations with CLICE about the best, the timing of that, recognising we'll need to go out conversations in respect of the work on developing Neville Hall site. So it's not been agreed yet. It's the short answer, Louisa. We need to think about in terms of the handling of that and the changes.
And I think just on that point, and we pulled it out as part of our JET, is some of the service changes we've driven this year. Stroke reconfiguration was a huge effort in a small period of time, moving the St Willows roads down to the Royal Gwent, all the work that was done on the minor injuries unit. You know, those three in themselves were significant pieces of work that you know, the maternity, finalising the maternity review was another one. So there's been a huge amount of work of trying to reconfigure services where, thank you, we will be picking up that this year. Thank you.
Thanks, Louise. Any further comments? No, if not, what might we move to section 2, the patient experience and public engagement. and turn to the patient's story, which is about respecting patients' wishes at the end of life and improving communications with families and our bereavement offer. And I'd like to welcome Tanya Strange, who's the head of nursing for patient-centred care, and also Julie Hopkins, who is going to present her story. And I'm very grateful to you for attending, and thank you. Jenny?
Just very briefly from me, and thank you to Tanya and Julie. We've reflected a lot, I think, on our end of life and our bereavement services within the organisation over the last year. We know that those touch points at the end of life are the things that stay with people for the rest of their lives. If there's a poor bereavement or end of life experience, then people find it very hard to cope with that. So for me, it's morally one of the things we absolutely need to address. And also, from our perspective, if we can make those last few moments or those last few days supportive, pain-free and comfortable for the family and support those family members afterwards, it's, I think, the least we can do, and it's really important for us to do that. So I'm really pleased that Julie has reflected on her experience, has given us the opportunity to draw on that and to understand how we improve as a result. And attached to in your appendices, you'll see the output of the Bereavement Collaborative. Yes. And the Bereavement Collaborative report, which talks about next steps, but also talks about the power of some of the conversations that happened on that day with our conversations with the public. So I very much commend that report to you as well. But thank you. I will pass to Julie and Tanya.
Thank you for the opportunity. I think it's probably for Julie to open up the session, really. So over to you, Julie.
Thank you, Borodar. Thanks for asking me to come along. I'll keep it short and sharp because I think the most important thing today is sort of for Tanya to feedback on the work that's been done and the Bereavement Collaborative work as well. But if you're happy, I can give you just a really short introduction with a bit of a timeline so you can get some context about the story. So just say that my husband had quite significant comorbidities, really, diabetes, fibromyalgia amongst two of them. And at the end of October 2021, where does that time go? It's always like looking at that photo, actually, when I was like 30 years younger. So, yeah, he had some blisters come up on his foot. So he was admitted to the medical assessment unit in the Grange because it was suspected that was a complication of his diabetes. And it's fair to say that he was not the most disciplined in monitoring his blood sugars. So he's a big get on that. When he went in there, it was found that it wasn't to do with his diabetes. It was cellulitis, and he was treated for that. His blood sugars were stabilised. And after 4 days, I spoke to him, and he said he was being stepped down to one of your local hospitals. He was obviously very happy about that. The step towards coming home, and I was told that he would be transferred. So this was on a Thursday. So Thursday evening, I had a phone call to say yes, he was being transferred. And someone would contact me on the Friday. Well, somebody, of course, did contact me on the Friday, didn't they, to say that he passed away suddenly. So just to say that my daughter had just started a student in Bristol. So I then had to ring her and say what had happened. She was already stressed because her dad was ill and she was away from home for the first time. So I was asked if I wanted to go in to see him, which I did. I had to wait for my daughter to come back from Bristol. We went in, he was in a 4-bedded ward with pretty tatty curtains, to be honest, pulled around him. The other 3 beds were occupied. So, very nice for them, was it? It was a ward clerk that greeted us. She gave us some tissues. It was very nice, but there was no nursing or clinical staff to talk to. I asked had a priest been called, because that would be so important for him. I was told no. One did arrive about half an hour later, and to give him the last rites, and we left. So obviously you go home and try to process it all, and I had questions that I wanted to ask. So, I wanted to know about the safety of his discharge. I wanted to know what his news score was through the night, or how was he monitored. I wanted to know whether attempts had been made to resuscitate him, and I wanted to know why his religious views hadn't been respected. So I tried to contact the places where he'd been. Nobody rang me back, and after about 5 days, I rang the medical examiner myself because I really wasn't happy. They were lovely, and they told me that it had been referred to the coroner and there would be a post-mortem that goes through the process that it does. And we were eventually able to bury him about a week before Christmas. So clearly my questions still hadn't been answered, and so I didn't feel I had any option other than to put in a formal complaint, which I did. I had the acknowledgement in line with the regulations within 2 days. An investigating officer was appointed. They never contacted me. I never had any contact with the investigating officer at all. And after a few months, I was back in work. My daughter was back in university because she had to go back. I thought I can't keep dealing with this anymore. So I handed advocacy over to what was the Community Health Council at the time, who were lovely, I have to say, and really supportive. One last go, I ran the central sort of PTR team that you have, who again were great, and the consultant who actually did my husband's mortality review and gave me a ring and gave me some explanation about what was happening. So they went to redress panel, which he did, and then eventually I had a letter, nearly a year after he died. I finally had a letter. I didn't think that addressed the 4 questions that I had. It was more a kind of summary of his clinical care, to be honest with you. And so I then took that to the Ombudsman. The Ombudsman did an independent clinical review, which found no issues with his care. But obviously they upheld the bit about complaints handling. So we're just going to hand over to Tanya now to say how the 4 sort of key issues that I had were addressed.
Thank you, Julie. So Julie has done a digital patient stories. If anybody wanted to see that, Michelle has said she can send that later. But we took Julie's story first of all to the Deteriorating Patients Collaborative, because even though Nick wasn't expected to die, it was really important to outline, you know, he had stepped down, there were comorbidities, but I think the fundamental message would have took 6 months for you to know that attempts had been made to resuscitate him. So it was just making sure that people learned from that, and that was really well received. We've also taken the story to the Quality and Patient Safety Outcome Committee. Divisional teams have seen it, and we're having requests from other teams to have the story so they can learn from it as well. Picking up Julie's point around the bereavement, we held a couple of drop-in bereavement sessions across the hospital for staff and patients and carers to come in and see us. Our PALS officers now are filtering any concerns to do with end-of-life bereavement, etc. And we decided as a collaborative with Steve Edwards as the medical lead that we needed to hold a big conversation, that actually we haven't done that in the health board. So we held that on the 20th of March this year with the assurance to people that we would use their experiences to make a difference. Next slide, please. So we arranged it. Sorry, I'm on the big conversation. Oh, sorry. The next one, sorry. So we organised the event through Eventbrite. That was a challenge. That was probably more of a challenge than holding a big conversation, actually. We organised prayer rooms because it was during Ramadan. We asked the people there if they wanted to. We provided them with little paper hearts, and if they wanted to leave a message to those they'd lost, you know, they could do so, hang them on the Tree of Hope, and those messages would be embedded into the new bereavement model as a constant reminder, really, of how important this is to people. So the morning session was very much focused on key presentations around the bereavement standards, but we specifically did a presentation on religion because of Julie's experience. So although that isn't embedded in the standards, it was really important that we covered that. The afternoon session, then, there were 9 conversations on different topics, and they weren't just topics that were in the bereavement standards, they were topics that we picked up from themes of what people have told us over the last year. And everything, all those roundtable discussions then fed into a big conversation when we picked up the themes. So the next slide, please. I won't go through all these, but these were the roundtable discussions. Actually, one of the most important presentations that the audience related to was advanced and future care planning. That's not in the bereavement standards. But Cliff Jones gave an excellent presentation on how important it is to find out what matters to people, not just at end of life, but from diagnosis on. So we've taken a lot of that a lot of that work forward now. And we also linked in with the chair of Muslim Doctors Cymru, who was, you know, very vocal and rightly so to say that advanced and future care planning isn't a one size fits all. We have to consider the cultural needs of people. Next slide, please. You'll see in the actual bereavement report, there's a lot of messages in there from people who've lost loved ones. Everybody bar none said that that day helped them feel less alone, that they weren't on their own with their grief. So we'll just go quite quickly through the main themes, if that's okay. Michelle, can I have the next slide, please? So I've said about advanced and future care planning. Anticipatory grief came up as another issue that, you know, people need to be better prepared, that they are likely to lose somebody. And we have worked with crews to develop an anticipatory grief training programme that we've just piloted. We thought we'd done really well in updating our website with all this bereavement information, and we were told that that's not good enough. You know, you can't post people to a website. There's wonderful information on there, but at the time that someone dies, they need that support now. So we are looking at that. Recognition of baby loss under 20 weeks. There were a lot of comments on that, and we have just done another patient story of a lady who's had two losses. I can't remember the word for it, but before full term. And actually the loss of her baby at 6 weeks was worse for her than a baby over 20 weeks. So we're having some discussion around that, but there is some national work taking place around that, because England will issue a certificate, if you like, for baby loss under 20 weeks. We don't currently, but they are looking at that on a Wales-wide basis. Next slide, please. Yeah. Communication really speaks for his support. We have had a number of people that came to that would like to be volunteers with us, so that they would be volunteers by experience, if you like, and to support other people who've been bereaved. So you won't be surprised to know that Catherine is on to that one already. Suicide, particularly suicide over the age of 26. There are some particular issues around, you know, funding of those services. And that's right across the piece, really. And community deaths. If someone dies in hospital, they're more likely to be contacted or followed up than somebody who dies in the community. And what one of the ladies said to us was, you know, someone dies at home, the door's shut, you know, we're left to just grieve with it. So we have picked that. The medical examiner came, so we did pick that up with him, and we're having some discussions around that at a national level. And then finally, there was a lot around staff training. People won't be surprised to hear that. Recognition, really, that, you know, for our staff to recognise that someone may be at risk of complex grief. The need to look at the changing face of religion. So the chaplaincy team are not being called out as often. I know they came to support you Julie, and rightly so. But there is a need for more pastoral support as well, so it might be a more spiritual thing. Non Ellis gave a fantastic presentation on the bereavement needs of people with protected characteristics. That was really powerful and made people sit up. And the other thing that came up, and Julie's alluded to it, is the need for family rooms when someone dies. And Rhian Manning, as you know, Nicola, with her experience, you know, there needs to be dedicated rooms. Sorry, next slide. Sorry, next slide. I'm one step ahead of you. I'm sorry, Michelle. There was some discussion around the terminology that we use, and we use it across Wales as the care after death. People don't like it. You know, people who are bereaved don't like that terminology. I think it's that the death is you know, right in your face. So we've had some discussions around, actually, should we be calling it loss and bereavement rather than care after death? We have challenged Welsh Government, because it's in their documents that every health board has to have a care after death team. But why? Why do we need to call it that? And we have got people's voice now telling us we should call it something else. So we're having some discussions around that. Death certificates. is a big issue at the moment, delays in those, but the new reforms with the medical examiners should actually improve that going forward. We're developing the bereavement model now and develop it through a cultural competence model from the outset. And we are looking at local conversations, and we've got the first one on Friday. So we'll go to each borough. We've got the first one on Friday in Abergavenny. Everybody was supportive of Grace, and I know we've mentioned that before. They didn't like the original logo, which was too spiritual. So, oh, sorry, Michelle. Oh, I'm so sorry. I hope you've got this presentation, everyone.
If you go back that one,
The logo at the top is the one that we will use to brand the model going forward. So going forward, now we're on the last one.
Next one, Michelle.
Going forward, as I said, we've got the big conversations coming up in the boroughs. We're looking at all medical examiner concerns that come through around, end of life, death, all the complaints. We're putting on our letters now that if somebody wants to discuss their end of life experience, bereavement, to get in touch. And there are a lot of people getting in touch with us right now. We've got 80 people that are now part of the bereavement collaborative. 50 of those came signed up at that event. So we've got another collaborative at the end of June. And the other thing I think is important to mention is that some of the feedback around advanced and future care planning is the need to have a public campaign so that people know what it is. And that's been picked up in the end of life care board, which is really well received. And we would like to develop Grace's Place. So it'll be support groups in the community for people who've been bereaved, run by bereaved people themselves. So just to end, I'd just like to pass back to Julie so that she can hopefully outline her reflections on what we've done as a result of her sharing her story.
Yeah, thanks. I'd like to give you the opportunity to do that because I don't feel like you're on your own. You've got family and friends and work colleagues around you. It can be quite an isolating time. So having the opportunity to share my story and to work with Tanya and the Bereavement Collaborative was an excellent day. It really was. And so you realise, the wealth of people's experiences. So it's been good to have that. And I just want to say Tanya and the team for the opportunity to be able to do that. And just to say, in my role, working in a national role, so I've been able to influence the change to the PTR guidance, which is coming out. I shared my story with the person who's leading that, and there is now a specific section in there on bereavement. So I'm really quite pleased about that as well. So, yeah.
Thank you very much, Julie. That was a grueling story, but my goodness, I think you've given us a really good shot to improve these services, which are absolutely vital because the experience stays with you forever, and it's
one chance always to right.
Yeah, exactly. So thank you, and thank you very much for having the courage to share it with us today. And thanks, Tanya, for your support. Are there any questions, Nicholas?
Yeah, can I thank you, Julie, and thank you for your story. And it sits quite close to me that first of all complaints process. The lack of communication is one of my biggest frustrations when I'm signing off complaints and then I'm not content with the communication that's happened. And it's something Jenny and I are really committed to improving, because whilst we get it right in lots of cases, we are still not getting that right in still too many with that communication while people are going through complaint, potentially suffering bereavement. Is just not good enough. And I share your kind of PTR, the regulations. Some of it brings a coldness to responses that, again, that I know we're obliged to put in, but sometimes it doesn't fit with the compassion that we're trying to demonstrate. And the additions we've added to our letter now around the bereavement offer, we can add at the end of the complaint to say, please join our kind of collaborative, and if that's what that person wants. So it's such a great addition. There was a baby loss complaint letter recently, and the ability to be able to offer some more support and a reach out, and it is so much more powerful. So I'm really committed to trying to get better constantly on this. And as Tanya knows, I feel really passionate about our bereavement offer, supporting them. They love the Grace theme. I like the old logo, but I love the new one. And you know, the Grace's place and that opportunity, because I think from other services, that peer support is absolutely fundamental in terms of helping people's kind of recovery and sharing experiences with people who know what you're going through. So thank you, and I'm glad you're part of us trying to get. We've got lots to do, we know that, but I think we're making really good progress in the direction with which we want to go. So thank you.
Thanks, Nicola. Are there any further questions? Paul?
I'd just say to thank you for coming today, and I think it's a sort of a cathartic opportunity really to sort of put things right. But I think it's also wonderful looking at the information on what's happened since. I think it's a great achievement, and as chair of the charitable funds, I think it may be useful for us to have a conversation about how we can look to develop something, and not this particular model. I think is a great one, because I'm not aware this is happening in many other places. And I think the whole issue is very much a taboo subject. And I think it's about having conversations, to be able to have those conversations and share with people and get some sort of feedback and help and support. I think makes a big difference. So, very well done, and thank you for coming to share it today, because it would have been difficult. We appreciate the fact that you've given the time. Thanks, Tanya.
Just a massive thank you to Tanya and to Julie. It's a big deal onto a board and to share your story. And we've turned something very dark into something that there's no light for. And the important work we can do now to work with Julie and the other 80 odd people that have come forward is really important in driving forward how we do get this right.
Yeah.
So a massive thank you from me as well.
Thank you. The big conversation.
Oh, the big conversation report. Yes, so we've appended that. That's already been through to PQS. So I won't take you through it in detail, but it is very detailed about the experiences people shared on the day. It's very detailed about the actions we're going to take, which Tanya has talked through. And it details, what our ambitions and our plans are for the future, very much so, in terms of how we want to listen, react, and put into place a different experience for people. It doesn't change Julie's experience, but Julie's experience can make it different for the future. And that's what's important. And that's why the bereavement offer needs to be something that we build from the ground up with people who've experienced that. Some of those may be our staff. Yeah. We've had staff come forward who've had poor experiences, and some have had good experiences. So it's how we wrap that offer into something that makes sure we've got all of the things in place, right from the point at which really this starts in the last 1,000 days of life. You often hear that, but the advance and future care planning, those early conversations, those supportive conversations with people about what they want, because we often get very paternalistic and make decisions, but this is about what people want, and we need to be able to provide the support in the right place. And it's not, this isn't about more money, it's about wrapping care and services around patients and families in the right way.
Can I just ask one thing about advance and future care planning? Because I very much appreciate that this is focused on the individual and allowing them to make the decision they want. But I think it's pretty daunting when you are the enactor of the actions, because you've had no support. You might know what they are, but you've had no support at all. And the way in which the question is asked can vary very much indeed, depending on how well the clinician, usually a clinician, has been trained. And I think, could you think about how do you put a bit of support around the person who's left with the decision to say, okay.
Yeah, these conversations are never easy, and in some ways, this isn't just about patients with cancer, and largely it's been focused on patients with cancer. This is about all pathways. If you look at dementia care, you might be having a conversation 5 or 10 years before, the end of life period, and things do change. I think, we're lucky within the Health Board that our, it's now called Future Care Planning, our Future Care Planning lead is also the national lead. So there is a big piece of work happening nationally, looking at how you provide that sort of support, not just on the documentation, but support for the individuals having those conversations, the training, the supervision, the follow-up, because they're really, really hard, particularly if you're a consultant or a, advanced nurse practitioner or a therapist who's been working with somebody for a long time. Starting those conversations are never easy. So it's the wraparound offer and support. So from my perspective, Anne, absolutely, for me, it's not just about the completion of the document, which a lot of people think it is. It is about the holistic offer. And also then, how do you support people as things change? Because people do change their minds, things do change. How do we make sure that we're continually asking that question in a supportive manner? And it's not an easy piece of work. There's a lot of work to be done, nationally. But I do think it's the right thing to do, and it helps. It also helps. The reason we've, I'll come on to it later, we've put the end of life programme into the 6 goals programme, because actually it's implicit to some of the work we do on admission avoidance, on discharge. It is such a wraparound programme in terms of all of the pathways, all of the work we do in urgent and emergency care as well. So for me, it's the right thing to do. I think we've got a lot of work, as every other organisation in Wales does. But I think we've got a real opportunity, I think, particularly with the public engagement we've now got, to do things in the right way. And as I say, we've got a really energised group of clinicians who want to work with us. Cliff obviously gave the presentation as well. He's leading for Aneurin Bevan. And we've got Aoife Gleeson, who's the other clinical lead, who's very focused on this.
Thank you. Are there any questions? No? Well, thank you very much. I think that was a really valuable lesson of what can be achieved through listening and doing something about it. Thank you. Could we pass on to the report from SICE, please, Gemma?
Morning, Chair. Thank you. Morning, everybody. Yes, really pleased to present my final report before my successor, Lisa Charles, takes over in June. I think just to touch on the complaints side of our service at the moment, and this does touch on the patient experience story that you've just have. I do recall our advocacy service supporting Julie at the time of her complaint. We're seeing at the moment an increase in ombudsman submissions, and I know that Julie mentioned that hers progressed to that point. And our reflections as a service are, because of some of the delays and the pressures within the complaints process at the moment, people are often waiting a long time for their responses, and that does then bring them close to a time restriction for the ombudsman. So when we get a response, it may be, very well constructed and have good detail, but if our clients have even a niggle that something is unanswered or unresolved, because of the time restrictions for the ombudsman also, we're finding that we do need to escalate concerns a bit more to the ombudsman when potentially a meeting with the service on a person-to-person level might have addressed that complaint and prevented the person from needing to, or thinking that they need to, go to the ombudsman as their last resort. I know in most cases the ombudsman, will be very fair and considerate of complaints and say when they feel that complaints shouldn't be investigated further, or the complaints that do go through to investigation might find that clinical care was appropriate. That time with the ombudsman might have been better served earlier with a meeting with the health board, with the service provider, just to offer that person a conversation. So I think I'm just offering that out as a reflection that we're in a catch-22 situation at the moment where complaints responses are delayed, and then if there is even a niggle of a unresolved issue, we must inform our clients of the ombudsman's deadlines, which does influence their decision to come away from local resolution when a meeting might have helped. So I just think that's helpful for me to put out there. In terms of the rest of SICE's work at the moment, I can confirm that we are involved with the stroke rehabilitation service and wider ELGH reconfiguration model. Really happy to continue that conversation with your planning team when the approach to that has been agreed, and we have the preferred approach. So please come back to us for further meeting when you need to. In terms of our engagement across Gwent, we are focusing around our 3 local and 2 national priorities. And you can see from our report that we are receiving some thematic feedback, largely to do with communication in other languages. And we're hearing more now through our engagement, but also through our complaints about people who feel that they may have been discharged, not necessarily too early from hospital, but discharged back into the community without the appropriate package of care in place. So they're then waiting a little bit longer in the community for care that they need, but they've been deemed fit for discharge from the hospital. So there's just a bit of a gap there in service that people are concerned about, and that issue is increasing in the feedback that we're getting from people. So within the next few weeks, we will be publishing a survey and offering people the opportunity to share stories with us about any delayed discharge from hospital that people experienced and what it was like for them to access a community service that they might have needed upon discharge. So that survey will be open for the remainder of 2020, for the remainder of this financial year. Our team will provide services with regular briefings as the survey is live, so that there is some live feedback. But then at the end of this financial year, we will produce a formal report about the total feedback that we've received through the life of this survey, just so that we can wrap recommendations and learning around it formally and make that a public document. So we are trying to wrap some of our activity around the feedback that we're hearing now. I know the board will be really pleased to hear that we've separated our report out to engagement with young people. I know that that was an important ask at the last 2 board meetings. So you'll see that we've had the opportunity now to attend engagement events where students and young people have been present, and some themes in GP access, dentists and mental health have come up. Largely, we needed to explain what we meant by asking the question about what is it like to access health or social care services for you. So we needed to give some prompts about, this is about accessing any GP services, dentists, pharmacies, any other services that made that a bit better understood to young people. And what we found were some of the predictable things around access to GPs. Concerningly, some people waiting a long time for a GP appointment for skin condition. I think there was just a little bit of a theme about when young people access or contact services, about the approach given to them being a little bit dismissive. So being told that they're not urgent, or they're waiting 3 years for a mental health appointment and that it will be gotten around to. So I think what we're going to start to hear more from young people is about their communication with services and how that is handled, so that they feel important and heard, and that their needs are important as well. Our trauma and orthopaedic hips and knees survey has concluded. We did hear from 47 people. And as expected, we did hear a lot from people about the pain and discomfort that they're waiting in, even though physiotherapy or pain medication might have already been offered. But we know in the background that the Health Board is launching the Keeping Well service. So I'm hopeful and encouraged that that service might wrap around people in this particular instance. But now that we've gathered the information from people, the report will be with you as soon as possible to potentially influence this Keeping Well service. And I'll pause there to take questions, please, Chair.
Thank you very much, Gemma. That was really helpful. Are there any questions to Gemma?
Yeah, not a question, but just to comment, Gemma, I thank you for your reflections about the complaint process. I think, as Nicola reflected, we've already picked up the communication issues, and in the last couple of months, I've sent 2 very urgent complaints, which were quite simple, back to my team, and they've had a conversation and it's resolved the complaint. And, there was no need for a formal response. Things have moved on. So I think we are going to set some communication expectations standards. So the expectation around keeping in touch, expectations around meetings. And I've certainly asked the team to make sure that, certainly for any of the older complaints, we have a conversation first before we send a letter, because we run the risk of resurfacing issues that perhaps people have put to bed, or, you know, we're not acknowledging some of the further issues that have taken place. So I welcome that, and absolutely it's a rigorous focus for us.
Thank you.
Thanks, Gemma, and thanks for the offer to continue to work on how we shape what engagement should look like for this next phase of the ELGH work. And also the work about the T&O survey, keen to see that in terms of how we take that forward into the Keeping Well service and the work there. And I was expecting, I think I was expecting more people to have engaged in that. 47 feels quite low compared to the huge numbers we've got, but not to distract from the experiences and feeds for those patients who got in. And then just finally, just to thank you from me in terms of the work that you've done with my team and others over a number of years. And yeah, good luck.
Thank you. Also, we were quite surprised by the low number of the T&O responses, also given that we engage directly with service users through your T&O team. Yeah. So yeah, a surprising one, but valuable feedback nonetheless. Yeah. But yeah, thank you.
Yeah, thanks, Gemma, and all the issues you've picked up are things that really welcome your feedback and things that we've picked up locally as well. So good to get that alignment. I just want to, personally thank you for all your support and your very constructive, supportive and challenging approach you've taken, which I think has been really welcomed and we've really benefited from over the last few years. And I wish you well in your new role. So I just wanted to thank you on behalf of the executive team as well, and Siobhan.
Yeah.
Share my views.
Yeah, the board would certainly do that. You've been extremely helpful, and that does not mean that you've been extremely compliant. You've tested us at every corner, but you've done it in the right way, and that means that we have really valued the work that you and your team have done for us and with us and for the people in Gwent. We will miss you a great deal. We've had a good relationship, honest relationship, and we wish you very well in the future. And you can come back if you don't like it.
I will. Thank you. That really means a lot. And thank you to everybody. I really, really appreciate all your kind comments. Thanks.
Thank you, Gemma. Thank you. Can we go on to section 3? The multiple sclerosis service expansion. Leanne.
Thank you, Chair. Just a few things to draw out because I think the paper is relatively self-explanatory. It's quite unusual, I guess, for this level of investment to have such a brief paper, but I just would draw to your attention that the business case has been through a very robust scrutiny process. It's been by our pre-investment panel with robust benchmarking and an evidence base. A copy of the full case has been shared with board separately due to the commercial sensitivities in relation to the case. So I just felt that was worth mentioning at the outset, really. MS affects about 1,500 patients across Gwent, and relatively recently, the All Wales Medicine Strategy Group recommended Fampridine. It's not NICE recommended, but a value for money assessment was done by the All Wales group that recommended we should be prescribing Fampridine for patients with multiple sclerosis in Gwent. Similarly, there's another drug that has been NICE approved, Siponimod. They like to create these drug names that are difficult to pronounce, as always. And so we have pretty clear guidance in relation to prescribing of these drugs for this patient cohort. And in spite of the fact that we have a very committed team in neurology overseeing these patients, we effectively are not meeting the standards we would want for our patient population. All other boards prescribe this drug, and I think the board are minded to support the case. It would end the inequity of access for patients in Gwent, the second largest population in Wales, I think, just to refer, and it is a significant concern, I know, for the board that we are an outlier in this regard. So a couple of things really, I think, just to tease out before I open it out to comments. due to the ability of the service sort of to scale up, the paper looks for approval for option 3 in its entirety, with a view that we would implement option 2 during this financial year, with the ability to obviously recruit into those posts as outlined in the case. There will be a review at year 1 in terms of the I guess recruitment success, the impact it's having for our patient sort of cohort, but that does mean that we've got a phasing, I guess. Our best estimate at the moment from a cost perspective is just under 500k, 455k for this year from an investment perspective, with an estimation as we move to option 3, noting the requirement for that service review at year 1 of just under £1 million, 964k. I would outline, though, that there are benefits to investment in this case, both in terms of admission avoidance, albeit that won't be cash releasing necessarily, but obviously from a wider economic benefit to society more generally around sort of the benefit that this drug and the annual review will provide for MS patients. And obviously can't not mention the enormous impact and benefit to individual patients for this drug. Just I wanted to tease out because it won't necessarily. So I know that there has been a keen interest, understandably, because we are an outlier in Wales in relation to our ability to, I guess, potentially approve this case. The plan from a service perspective would be to go to immediate recruitment to the posts. The service have a view that there are people out there and we will be successful in our recruitment. We will also be able to initiate a number of clinics with immediate effect, even though we won't necessarily have the full staffing complement in post. The patients, we have a list of patients that we are able to target. We will take routine neurology capacity in the short term to see and prioritise these patients if the board is minded to approve this case as well, which we will be able to make up for at a later point when the staff are appointed into. So I think it's important that with this potential sort of decision that we can move quite quickly, which I think is important for us. So just in summary, I would welcome the request is for the board to approve the implementation of option 3 with a review at 1 year with the option 2 implemented in 24-25. Thank you.
Thank you. Thank you, Leanne. Are there any questions to Leanne about this? Paul?
Yes, as I support the request, and I was particularly interested in as to whether we had an issue with recruitment. That seems to be sorted. Radiology and MRIs, I just want to be on the capacity of MRIs. That seems to be addressed with regard to the monitoring of the 2 drugs, and obviously that the pharmacy are able to also to be able to deal with the increased demand. So those are the areas that I'm pleased we're able to we've been reassured on. And just to check on the MRI, that is efficiency there, is there?
Yes, we've done a lot of work with the department in relation to phasing this so they're not overwhelmed by the actual sort of demand. There is ongoing work anyway, as I'm sure we'll hear about from a plan care perspective around diagnostic targets. So we're under constant review in terms of demand and capacity and ensuring we have appropriate diagnostic capacity to meet the needs of our patients. But obviously, the prioritisation of this particular patient cohort, I think, is pretty important for us. So lots of work to do for us as a more general issue in terms of diagnostic demand. I think some of our population feel that I think sometimes the diagnostic is part of the treatment option. So I do think we do need to do some targeted work when you look at some of the significant increases in demand. But this case, with the phasing, I think will be manageable for the department.
Yeah, the communication bit about that to the patients then, because if there's an awareness that the decision's been agreed, then it would be okay. When am I going to get it then? So I mean, some sort of communication to explain. Decision made. We've now got a programming, or will be putting a program in place with regard to staffing, medication, MRIs. I think that would probably be important.
The team have a very detailed implementation plan, Paul, as you can imagine, because this has been a long time coming on behalf of the patient. So I'm confident that they'll be able to cope with that. Thank you.
Thank you. Are there any further questions?
Can I just ask, I don't know if this is a question for you, Leanne or Rob. Is this going to be an additional cost in terms of the financial plan, or have we already factored this in some way?
This is in the financial plan for next year as part of our Nicola's earmarked reserve for priority commitments. This was one of them stated.
Thank you. Ewan?
Yep. Well, somebody's beat me to the financial question for a change. There's a couple of things, because to me there are two separate projects in here, or it feels as if there are two separate projects. One is the implementation of the generic drug, and one is the piece that we have to do. I think, I fully support the project implementing these new drugs. What's the dependency one on the other?
I think
obviously we've linked them together in terms of the finances. What's the dependency one on the other?
I think the view, Ewan, is that it comes as a package, as a bundle of care delivery from a service perspective. I'm sure James will be able to comment sort of better than me from a clinical perspective. But in order to achieve the full benefit in terms of the admission avoidance, the benefit for individual patients, that they are bundled together. So we also deliver on that wider societal benefit as well.
All right. James?
Yeah, absolutely. So it would have been completely the wrong thing to consider these drugs separately, because the drugs and individual patient may be appropriate for both drugs. And you'll see from the business case that a lot of the cost is associated with the complexity of the patient assessment, the follow-up. The drug costs are actually a relatively small part of the overall business case. And you're going to have to put in place the infrastructure to implement drug A, and you'd be absolutely missing a trick if you didn't think about drug B at the same time. And because the two address different aspects of MS, and it's actually been really welcome to me that the team has thought about the infrastructure at the same time as thinking about the medicines, because that's something that often gets missed out. And this is a problem being replicated across multiple disease areas, that we have drugs that are complicated to use, that need experienced nursing staff and key decision makers, both deciding when to start treatment, when not to start it, but also stopping it when it doesn't work, which is quite a difficult conversation with somebody with a life-limiting long-term condition. So you're absolutely asking the right question, Ewan, but I really don't think it would have been sensible to consider the drugs separately, because the infrastructure that would have needed to be put in place would be the same for both drugs. So this is actually the more efficient way of doing it.
Okay, and when you say the separate drugs, then you mean the generic version of the one that we're already using, plus the new drugs?
Well, so the team that's going to be put in place is sort of future-proof, because as drugs move through into becoming generic, they'll be able to assess whether patients can switch over, because even the world of generics has become more complicated than before, and a lot of the new drugs coming through are not the same chemical molecule. They're called biosimilars, and sometimes they have unpredictable effects on individual patients that require a nimble clinical service to switch to the cheaper drug, assess quickly whether it's working well enough, and then sometimes to switch back. It's why my job is really, really interesting, but it's also why it's getting harder to do unless you have the right infrastructure to support you.
Yeah, and I guess my question then goes into more of the, could we have implemented the generic side of this project? Or as I say, I think there are two projects, but the generic piece of it earlier. How long have these drugs been available for? It seems a coincidence that all of this is coming together, if you like.
Yeah, I think the fact we have brought it together has been part of our constraint. So one of the reasons we've been quite challenging around switching to the generic drugs, but one of the reasons James said is we haven't had the infrastructure to be able to do, because there's almost three projects in here. There's the two different drugs and there's the generic. And what the team, and one of the reasons there's been a delay is trying to put together that comprehensive case that brings all component parts together. So we maximise the value of that infrastructure investment to get the generic drug savings and be able to implement the new ones and make sure we manage patients effectively as part of that, given the complexities as James has set out. So this does it also enable us to deliver that generic drug switch as a result of the investment in the infrastructure. And that's why it's taken us some time and we've been delayed, is because we've been keen to do this as a comprehensive piece of work rather than doing them in small parts, really, which doesn't then achieve the overall aim of the neurology service and managing of MS patients. Hopefully that's helpful. Pippa?
Yes, I just wanted to say really that we're not talking about a tiny number of patients here. We're talking about a significant number of people, and this is something that's going to make a big difference to people's lives and quality of their care, and not just in the here and now, but actually in that kind of future space of how ill people become later on in the disease progression. And so I just wanted to say really that for me, I'm just fully supportive, and I didn't really have any questions, but I just wanted to make the point that it's something that's going to make a big difference to a lot of people.
Yeah. I think a key follow-on from what you said, Pippa, is that we're suddenly going to be able to offer treatment to people who've never had a treatment available to them before, which is why you need the infrastructure to cover it. And, you know, it's an area that we're addressing in a different way in severe asthma, my own area of practice. It's about 3% of all asthmatics, but we've gone from being only able to treat 20% to being able to treat 100% in the last 3 years. So, you know, making sure you've got the correct, efficient infrastructure is absolutely essential, because these drugs are very expensive, and the way of using them prudently is to start them and stop them when they don't work, and that requires quite complicated decision making, as I'm sure you can. Lots of good communication.
Are we content then to adopt this and agree the business case? Thank you. Thank you. Moving on to 3.2, our RPH decontaminated unit.
Thank you, Chair. So the purpose of this item is to seek the board's approval to submit the BJC, the Business and Justification Case, to Welsh Government, so that we can access All Wales capital of just over 4.7 million. This business case should be seen as the natural phase 2 of the endoscopy development that we've referred to previously, is opened in Gwent Hospital, was always the intent for the one to follow. And for that reason, it does rate highly in our annual plan and our prioritisation for capital investment for this year, and that we returned as part of that All Wales prioritisation exercise. So there's obviously lots of detail in the BJC and in the cover paper. Give assurance it has been through the internal PIP process, the pre-investment panel process, and the exec team. But in terms of summary, the development is required to respond to two main sort of drivers, really. One around demand capacity activity, and more importantly, one around compliance with standards and the management of risk. In terms of the capacity, the facility is required to deal with the increase in decontamination demand following the development in the Royal Gwent. Just to remind us, we went from 2 suites to 4 suites, and practicing, I was going to say operating then, whether the right word is, practicing on a Saturday as well. So huge demand increase for decontamination services, but also there's the capacity required for other services in terms of the neurology, bringing that together as well, and bowel screening Wales. And secondly, and as I said, more importantly, non-compliance issues in terms of the JAG standards. So, and what the standards set out by the All Wales endoscopy programme, and had lots of, we've got reports, some of them quoted in the BJC, in terms of the challenges with the current arrangements, in terms of flow, separation, traceability, and workforce currently working across a number of areas not dedicated to decontamination. So they're the drivers for change. The preferred option will see the development of a central decontamination facility in the Royal Gwent, bringing together endoscopy and neurology scoping into the old and now vacated endoscopy unit in the Royal Gwent. The paper and business case does outline that currently this from an endoscopy perspective is being provided from a mobile unit, which is very challenging. I'm sure Leanne will come in and share some of the team's challenges in terms of operating from that facility. But the preferred option would see that addressed through this development. From a revenue perspective, I'm sure colleagues will recall that the sort of base business case for endoscopy did see investment into Decon, just over 1 million, which is in place to support that additional activity. There is a revenue impact in terms of bringing urology in and disentangling the roles, but that, as you'll see, will be offset by the need to no longer have the mobile unit, which is currently being funded through revenue. So leaves a small manageable within service cost pressure. In terms of timelines for delivery, assuming the timely approval, and Welsh Government are keenly waiting for this, not least because of some of their decontamination advisors' concern and keenness to get this going. But if this is turned around in terms of if it's supported today and goes through the usual processes with Welsh Government, the current timeline is construction to commence October 24, complete July 25. So that gives an indication in terms of when some of the changes would happen. We are working with Welsh Government. Welsh Government are keen to see if we can bring any of those timescales forward, but obviously dependent on our conversation today. Next steps, subject to discussions today, in terms of there is obviously an implementation plan in place, but to review that, recognising that this development would sit within a wider context of changes in the Royal Gwent. So just in terms of aligning the activity on site and the various plans, I think one of the main interdependencies would be around the pharmacy robot. So lots of sort of detailed logistics to work through. But that's all I'll say. I don't know if before questions, Leanne wanted to add anything from an operational perspective.
I think the blue box, as it's been fondly called, which is not really very fondly thought of by the service, is being managed at the moment for sort of the immediate risks, but that is not a sustainable solution for us. We can't hold that for any long period of time. We are mitigating the risk with some of the actions we've taken, but that is with the full knowledge that we need to move to a sustainable sort of solution. I think at its most extreme, there is a risk that the All Wales decontamination lead will pull the plug on our ability to decontaminate our scopes, which would have a massive service impact from a delivery perspective, and is less than optimal for the staff that are running it as well. The environment is very poor. So I think just welcome any support, recognising I think particularly Welsh Government are keen to see if we can bring this forward. I know the service would definitely welcome that as well. So support for the case would be very much welcomed.
Thank you, Leanne. Hannah? Pippa?
I've just got a question really about the mobile unit and what happens to it, assuming this goes ahead. So obviously it's being funded out of revenue at the moment. So what do we do with it? Do we hand it back and just get the money back, or do we turn it into something else, or what? I didn't see it in the paper. That's all.
Yeah, go on.
Yeah, so we would hand it back. We're renting it, releasing it in the right languages. So it's sort of bespoke to, not quite a porta cabin, but it's bespoke to decontamination activities. So yeah, it wouldn't be repurposed for anything else. It would go back.
Okay, so it's a simple money back, basically. Okay, thank you.
Ewan and then Helen.
Yeah, I think you've answered it, Hannah, but it's just a check on the language within the document itself. In a number of places we assume urology is going to move in, and we assume we're going to do. Are these definites, or are they still to be discussed? It's just a strange language in a business case that we assume that we're going to bring things in, or assume we're going to do things, rather than this is what we're going to do.
Yeah, apologies, Ewan. That's just a language error. The plan is for urology to come in into this. This is predicated on that. So apologies for the poor language in that. It's a given. It's part of the plan. It's one of the risk areas that needs to be addressed. Urology staff are working both on decontamination and patient care, so that has to be addressed. So yeah, that's a presentational and language error.
In terms of that, then would there be a staff saving then in those other departments? that needs to be brought into this business case, or?
There would be an opportunity in terms of staff, because staff would no longer be doing decon activities.
So why haven't we brought that into this? Because at the moment, if you look at the business case, we'll be doing what we're doing currently, but it'll cost us 20 grand extra. Why are we not bringing those benefits into this business case? Because to me, this is almost a slam dunk of a business case. But when you look at what we're going to deliver, it's costing us 20 grand extra without, you know, additional benefits, if you see what I mean.
Yeah, I think we can look at that in terms of what the opportunities would be in neurology when some of those activities of decon have gone, because they'll be provided by specialist decon to strengthen it and mitigate that risk. Be a conversation between two divisions, but we can pick that up as part of mitigating that 20k.
Thank you. Okay, Ewan. Helen?
Thank you. Just to be supportive of this, obviously increasing use of endoscopies, all sorts of scopes these days in many different areas of medicine, and obviously to improve both the diagnostic process and the treatment. It certainly has taken off in the last 10-15 years, so supportive of that. And obviously it's a big issue regarding patient safety and also for staff safety with the decontamination, so supportive, but obviously aware of the financial constraints and the concerns from other people. Thank you.
Thank you, Helen. That's very helpful. Any further comments? If not, are we willing to support this business case?
Yeah.
And send the request in to the Welsh Government for the capital? Yeah. Thank you. Thank you. Thank you, Helen. 3.3, the gender pay and ethnicity pay gap annual reports and say.
Thank you, Chair. 2 reports to seek board approval for today, please. So the gender pay gap and our ethnicity pay gap. Both are presented data from our electronic staff record system as at the 31st of March 2023, in line with our previous reporting. Both reports split our staff groups into 2 categories. Those with the Gender for Change terms and conditions, which make up 94% of our staff, and then other non-Gender for Change terms and conditions, which are mainly medical and dental and senior management roles. But firstly, just some key highlights from the Gender Pay Gap report. We have a statutory duty to provide the gender pay gap information publicly by the 31st of March each year. And just to give board assurance that that information has been uploaded onto the government portal and is available in the public domain. It's not a requirement to provide a narrative report, but we always do so as best practice. You will see from the report the mean and median pay gaps. For Gender for Change staff, women get paid 83 pence for every pound that a man gets paid. And for the non-Gender for Change pay groups, that's 96 pence. The report also highlights bonuses, which are specific for medical and dental terms and conditions. And just to note that the bonus outlined in the paper is a voluntary scheme in which people apply for, but the findings show there's no differential between men and women who apply for those bonuses. In general, more men are represented in the highest pay roles. And you see from the report that 92% of our nursing staff are female, which makes up the highest proportion of our female staff groups. The report outlines also some next steps which we will take in line with our strategic equality plan, mainly around developing our women's network, which was established in March 2023, and looking at further opportunities through key findings such as flexible working, health and promotion of leadership and successive opportunity. The ethnic pay gap report, we don't have a specific legal requirement to provide this report, but we started to do so last year in line with our anti-racist approach. And when considering the report, its details looks a little different, but that is worth noting that there's within our electronic staff record, an opportunity for a blank record or unspecified record, which skews our figures somewhat. The key findings in there outline, again, against the Gender for Change, terms and conditions, 96 pence for every pound comparator, and for the median pay for 85 pence for every pound. And there are some next steps agreed within the paper, which are in line with our anti-racist plan and also our workforce race equality standards. And for both reports, we'll be working very closely in collaboration with a statistician from Cardiff University to better understand the reasons for our differentials over the next 12 months. And so there's further information in the report. Happy to take any questions and would request that the board approve the reports for publication, please.
Thank you, Sarah. Eva?
I'm pleased to see the ethnicity pay gap report, but I wonder if we end up excluding some, people from. So we've got other segments, haven't we, of people that work, and obviously we constantly looking at making sure that we have an equitable pay for our entire workforce. And I wondered whether or not it would be possible in the future to bring together, for example, our group of people who have disabilities who work with us, because we could end up with, for people over 50, for women, for ethnic groups, etc. And I wondered if it was possible to think about those people who we don't think are being paid the same as their peers for doing it. So it should be the same pay for the same work, regardless of who you are. And I'm not quite certain how you can isolate that. But if you're going to be working with a statistician, I wondered if that was something that you could task them with as well.
Yeah, so that will definitely be part of the programme for the statistician, because within the reports we note the importance of intersectionality and understanding those wider social factors that influence a pay gap. Although just to note, Pippa, as well, the job evaluation scheme that we've got in place should be addressing the equal pay issue. What we're really looking at in this instance is the pay gap between
Thank you. Any further questions? No? So are we happy to approve the publication of these two reports? Yeah, thank you. 3.4, finance report budget delegation, second stage.
Thank you, Anne. So the board needs to set budgets for each financial year, and for 24-25, at the March board meeting as part of the annual plan, we agreed that we had a two-stage budget setting approach for 24-25. This is that second stage. As a reminder, stage one recognised and delegated formal rollover budgets of a recurring nature that were already in our plans, or formalised them for budget holders for 24-25. So the aims of the plan is to basically establish delegated budgets to match the aspirations of the annual plan. We're using a funding envelope of £1.7 billion. To note, that includes £67 million of anticipated funding, which we are fairly certain we will receive. But it also includes £65 million of the conditional funding, which we have allocated to us already, but is subject to us making progress towards our control total. And I'll pick that up in the next paper for the month one position. We had to do a two-stage process on the basis that our annual plan identifies a deficit for 24-25 of £48.9 million. That is after savings delivery that we're expecting of £40 million, in addition to the £9 million we've got as savings full year effects brought forward from 23-24. So the approach is we've obviously got to set budgets within our income levels, but we do recognise that our plan generates a deficit. So the proposed approach 24-25 is to do the same as what we did last year, and establish a negative corporate reserve that reconciles to our deficit. That way, we effectively delegate budgets out to all delegated budget holders, and we maintain our corporate governance arrangements and our control frameworks and our assurance for corporate governance is aligned to our budget reporting mechanisms, which are well established, regularly monitored, promotes budget holder accountability for finance and performance delivery. So that's the approach that the paper proposes within the document. In terms of the stage 2 process, we've looked at all the parts of the annual plan, plus it's reflective of new intelligence, new opportunities that have come through as part of the updates to month 1 reporting and the last few weeks as well. So it's quite an up-to-date paper. In the paper, page 4 describes a 9-step process in terms of how we've used a methodology that recognises the approach that includes the annual plan cost pressures, the adjustments for savings we would expect, the application of new intelligence in terms of opportunities for savings, and then ultimately applies degree of stretch ambition, which is less than 2% for each budget holder, so we feel is realistic as a stretch target. And that's things like where we can potentially look at expected opportunities, efficiencies, and the opportunities throughout the year that arise. These are on top of and sometimes replace the £11 million opportunity in the financial plan. The ultimate aim is to set budgets for delegated budget holders that are reasonable, achievable, and do have some stretch ambition, recognising the deficit that we established as part of our annual plan for 2024-25. Thank you.
Thank you. Any questions? Can I just ask a couple of things then? Have we every confidence that the spenders of the resource are going to stay within their budget allocations at the very least and make further savings if they possibly can?
So in terms of, this sort of crosses over with my next report, but I'll deal with it now. So in terms of our financial plan, we assumed savings of £40 million. And we presented a worst case of 60 million and the best case, 48.9.
Yeah.
Once we've run month 1 reporting, our deficit for month 1 is just under £5 million. So that equates at this point in time to our estimated worst case. Yes. Now that I'm saying that as a positive in terms of we know that we need lead time to generate some of our savings. If we take a pure month 1 approach, I'm expecting us to improve on that position, and that's what we've all agreed to as a board and an exec team to deliver that. So admittedly, I don't have a crystal ball and there's risks emerging, but there's significant opportunities as well. I think the budget setting is reasonable, and we should expect all delegate budgets to live within their means.
Because the Welsh Government expects us to go further, don't they?
Yes, so I think from my perspective, and it's been discussed at the executive team as well, the reality is I think our plan is an ambitious plan already. We have got significant de-risking, I'll use that word, of the opportunities that we've already identified in the plan. So the £11 million opportunities that are being worked up, we've got about cover for 50% of those already, which is very, very positive. I'm not sure we're in a place to improve on our forecast outturn as identified in the plan at this point.
Yeah. Ewan?
Oh, sorry, I didn't realise I think you've kind of asked the question I was going to ask, Anne, in terms of, Robbie said, yeah, obviously we're implementing what we essentially implemented last year in terms of delegation of the budget and holding a negative reserve. Where do we gain assurance, therefore, that the outcome will be different? Or you mean, what additional controls do we have in place, you know, back to Anne's point of ensuring that the budgets are spent in the appropriate way? Or we stay within our budgets? You know, if we're doing the same as we did last year, how do we assure ourselves that the outcome will be different, I guess, is where the question is going.
Yeah, no, I think that's a fair point. And what I would reflect on is we've obviously got our overarching governance arrangements which are in place. We do need to make sure we are working to those, which we have confidence through audits, etc., like that. I would reflect in the latter half of 23-24 is when we established the Value and Sustainability Board within the organisation. There's been an awful lot of effort in the last. To answer your question, what we're going to do extra, I think the extra we've kicked in and established probably from about September last year when we did the mid-year review, and you know we got clarity on the extent of challenge there. So I think for me, it's more of continuing with that process, making sure we've got more focus on delivery sooner and acceleration. I think that's a legitimate challenge to us, is to accelerate and deliver the plans we've already described in our annual plan. As I just mentioned, it's not in the paper today, but since we've reported month one, we've got some opportunities de-risked, as I say, about 50% of those. So in terms of processes, I think we need to work out processes. They've been stepped up and increased in the last 6 months and make sure they now continue to deliver. I don't know if Nicola wants to add to that.
Yeah, no, thanks, Ewan. And I think it's a fair question and challenge. And I think it absolutely was what our objective was last year. I think what was clear is some of the underlying assumptions we had coming into the plan, as well as the savings. I don't think we still left a lot of divisions with a stretch that probably was beyond what they could deliver in the year. I think where we are now, I feel that the stretch we leave with each division is, after recognising we know that the savings are already identified, recognising the issues, as Rob said, that we've picked up. So I feel we're in a much stronger position to hold to account this year based on this budget setting proposal than where we were last year, because we still had a lot of the COVID related underlying issues caught up and we didn't quite get to where we wanted to. I feel this is a much cleaner position. Is actually closely aligned to where the forecasts are. And I know from Leanne's perspective, as the main is, you know, we feel the opportunities to deliver that stretch are there and absolutely can hold to account much better than we have in the past. And, you know, it's been a really important discussion that we've had about how do you create the right incentives and the right environment to really drive that improvement. And we feel that this budget setting does that, but we absolutely will be looking, as Rob says, our priority is to de-risk the plan. I think once we've done that, every other opportunity we'll be looking at to try to improve on the 48.9. So our first priority, as we said, is de-risking. Good progress already in month one, but we will be looking at opportunities, and we will then either through funding or moving, further budget adjustments to improve on the 48 if those opportunities arise and as and when. So I do feel we made a step in the right direction last year with this, but I didn't feel we quite got to where we were in terms of a line of sight of deliverability, without going into the complexities of the underlying issues. But yeah.
Nicola, could I just ask for a little bit more detail on that? Because I appreciate, obviously, that, you know, what lies ahead over the next 12 months, the further you look ahead, the more difficult it's going to be. So is the executive team confident, for example, that the next 1, 2, 3 months, you're going to hit these numbers and you've got some upside opportunity within that? Because, you know, if we are not hitting those numbers in month 1, 2, 3, then heaven knows where we're going to be at month 6, 7, 8. It's going to be a much harder position to get back from. So I'm assuming that there'll be a sort of monthly monitoring and reporting back of where we're at.
Yeah, well, absolutely. So the normal monthly process, the Rob's team, but we've also got the fortnightly Barrow Sustainability Board that is still running, that will maintain our oversight of the savings and making sure we're on track with our savings delivery and new opportunities that will be emerging. And keeping a really close eye on our run rate, our expenditure rate. And when we come on to month 1 report, you know, positive progress around our run rates on pay and non-pay that indicate that I think the biggest issue for us is to get in the bag that extra 11 million of opportunities we need to get us from, Rob said, the worst case of 60 to the 48.9 that's in our plan. That for me is the number 1 priority. It's only at that point can we then look at further opportunities and try to manage and mitigate risks that will undoubtedly emerge through the year, like they always do. So yeah, so I think we got the mechanisms in place to maintain an oversight of this. I
suppose when I come on to my next report now, I can reflect on some of those and explain a little.
Can I raise the issue about the demand pressures, and in particular, that reading the report I'm looking at page on the right-hand side, 216 of 829, the issue of the discharges that was raised earlier by Gemma, and in particular, 70% of the patients who are in hospitals that are not there for health-related matters are to do with social care, and 27% patient family-related nursing homes, etc. So we have 70%. We have got 289 patients who are in hospital that shouldn't be there. It's costing us 15 million, probably £1 million a month. Is there anything more we're able to do to eradicate that, or are we going to be in that situation forever?
Right, we'll come back there. So in terms of our numbers and estimates there, that's on the basis of us retaining the current profile, and that profile does move a bit. But that doesn't move much actually, but it does move a little bit between the categorizations. There's a lot of work going on, and colleagues may want to come in on this in terms of looking at how we improve our referrals through health pathways, how we improve our discharges through 6 goals, and ultimately then how we work in with our partners in new innovative ideas, as well as actually establishing pathways with them that work across the whole system. So there is an anticipation of improvement, and that part of our savings plans is linked to that, as well as efficiency metrics. And then to stay reductions effectively frees up beds. So there's a very active series of programs currently looking to improve that.
I mean, it's a terrific amount of work that's been undertaken, but these are issues that are not directly health board related, in the sense that the placements there. And I just wondered, effectively, we've got another hospital in place of 289 patients we're having to pay for, that in terms of budgetary terms shouldn't be part of our budget, and yet we are funding it. And you know, this seems to be the elephant in the room, probably not only and we've had this conversation before, I think, but not only in this health board, but elsewhere. So the reality is, of the money that we're asked to save, £15.5 million actually is outside of, well, our remit or responsibilities. But
so just in terms of the numbers, that's all delays. So some of them are due to us in terms of making sure our processes are being worked through. But there's a fair percentage that isn't, if you like, directly in terms of what we can influence, but we can't necessarily action.
I think in terms of our conversation with talking about the budget, I think just to make sure that the health board, we are making the financial people who are coming to look at us say we are already running another hospital of 289 patients, continue to have to do that without a budget effectively.
It is a nationally recognised issue. Yeah.
And I think it was and I raised it because I know it came up last week on the news with regard to what was going on in England as well as a big issue. We did a survey there as well. So just raising it into evidence gathering.
This has been discussed with the Minister again this morning. So she's very, very well aware of precisely the variety of reasons why people are staying in hospital and what everybody is doing about it. And she is in constant discussions with her colleagues on this matter.
That's good.
So it is an acknowledged issue.
Thank you for raising it.
I didn't raise it, she raised it. And we'll come back to it in the plan care programme anyway.
6 goals.
Well, 6 goals. I'm always getting the 2 mixed. 6 goals. Any other issues about the budget setting paper? Are we happy to approve this? This is going to be a big stretch. And we have got to be assured that the anticipated allocations are actually going to come into being, and that the divisions have got to manage within their budgets. They simply have to, because nobody is going to be in any position to pick up any overspend. Thank you. The finance report, please, Rob, for one.
Thanks, Anne. It does feel like we've done this a bit already, but
Well,
in terms of the paper and the document included, it's the full month one, end of April financial report for the organisation. In terms of key highlights, the revenue position is for month one a £4.9 million deficit. Forecast is aligned to plan at 48.9 million deficit. Our capital spend is 5.1 million, and the expectation is we will break even on that. Our public sector payment policy performance is 96% against a 95% target, and we have a cash balance of 2.7 million closing at the end of the month which is within the Welsh Government £6 million established level, so that's achieved as well. In terms of the revenue forecast, we've held the plan estimate at 48.9. Our in-house detailed workings at month one is forecasting that is achievable, so we've held that. The key point to note is that it's still 36 million above the £13 million control total deficit that the Welsh Government has set us. That's not sort of new information, but just in the point. In terms of income, the income does include anticipated allocations, and most notably the £65 million Welsh Government allocation that we received in 23-24 that was conditional on us achieving or making progress towards the £13 million deficit control total. I have raised this with Welsh Government recently, and at this point in time, they haven't said that we should not assume it. There's obviously implications if at any point in time that changes. So we're running with that as part of our annual plan and as part of our current 24-25 income base. Our underlying position again is reported as per the plan, £81.4 million coming into the year, with a forecast outturn as 51.9 million, reflective of us achieving recurrent savings in the plan as presented. In terms of operational points, pay is over £5 million lower than March. That's significantly driven by variable pay. So our variable pay in April was £6 million. Our average for 23-24 was 7.8, and our average for 22-23 was 9.2. So we've come a long way positively to make significant inroads into variable pay and positively reflected in our April position as well. In terms of non-pay, we're £10 million lower than March. Quite a lot of that change was due to services that we were hosts for in 23-24 moving to the NHS exec and other bodies, but it does reflect reductions in our specialised services commissioning and in our CHC and FNC costs as well, and aligned with plan. So again, if you also look at the Q4 position rather than the end of the year, there's a reduction in comparison with that as well. Because in March, we do find that we have a lot of wrapping up costs put through for the account. In terms of savings, We've identified £1.2 million delivered in month against the £29 million forecast, which we are continuing to report as achievable, and the £11 million expected opportunities are being expected to report as deliverable as well. We have reprofiled in month one, following a review with all the teams of delivery estimates. And we've also got RAG rating, which is on page 22 of the report, which shows how we have shifted from red to amber to green in terms of particularly the ambers to greens in terms of the year-to-date forecast. So that's a positive move as well. In terms of the reprofiling on page 23, you'll see that for obvious reasons, savings increase as we get past the 6 month point to reflect the workups that are required. We will be reprofiling this based on the work that's been done, particularly in May, to look at the de-risking of the plans, and I'd expect to report a much more positive position in that as part of the month two reporting. In terms of operational pressures, again, just because we've started a new financial year doesn't mean that the services change drastically. We continue to see delayed transfers of care, which we've just had a conversation about. Prescribing as prices have increased on our working estimates for April, but the volumes, again, as estimates for the year have reduced. So we've held the forecast as per plan, but recognise some of the price increases for April. As you'll be aware, they fluctuate significantly every month as national price changes are implemented. Activity is broadly aligned with plan, and financials reflect that as part of the annual plan estimate. CHC and FNC activity and costs for the month are aligned with the plan and forecasts. What I would say is the stage 2 budget setting that we've just agreed will allow the delegated budget reports analysis to make a bit more sense in terms of where the performance is aligned at the delegated level. At the moment, for month one, we're still holding that central reserve that offsets the positions to give us our corporate ABHP position. So to conclude, month one is for obvious reasons, is a very early position for the year. So we're intending to hold our forecast. Just had a conversation around confidence, so I won't repeat that. Yeah. As I say, I would expect our savings position to improve as part of the 2 months report.
Thank you, Rob. Are there any comments or questions to Rob? No?
Anything we can do to help at all with regard to the position? Because I mean,
I think, Paul, it's what I usually say is as and when we get some significant issues that need to come to the board, and we'll do our best to make sure that you're well informed of the implications as they affect patients and other factors, and be cognizant of where we are in terms of decision making. Thank you.
Yeah, nothing to say to Nicola. I think we're aware of the considerable pressure that the service is under. Just to thank you, team, really, for all the efforts being made. But I think that we have to recognise we have a responsibility to ensure we keep within the budget, and please do all we can to help and support you in order to achieve that.
Thank you.
Yeah, I think on the back of that, so I had a recent escalation meeting with Welsh Government, on the back of a speeding targeted intervention, and particularly, the being really open and shared all where we are financially, and that work is then considered nationally alongside other health boards, and that's one of the things we've asked is, from the data we've seen, not an outlier. If anything, we'd an outlier because we've got the highest savings plan, again, in addition to last year having the highest savings level, recognising where we are. We're not an outlier in terms of cost growth. In fact, if anything, I'd say we're an outlier in that our cost growth is not as high as others. It's lower than the average for Wales in prescribing secondary care drugs, CHC. The bit that comes out is we still got opportunities around our variable pay, around agency. That's which is really reflects the progress we've made and the further work. So again, we've made sure we've asked that if there are any, by doing that comparisons across Wales, there's anything that we're missing or opportunities we are not thriving, others are, then to kind of share that with us. But based on the high level analysis that's been shared, I would say we are going further than others because of our challenges. So I think fairly content we've got a very ambitious plan that we are progressing with. But absolutely, we really call on your support where we need it. Thank you.
Was there anything really useful to us from suggested at the escalation meeting? Because the executive is supposed to be there to add to our pool of knowledge and experience. And I just wondered if they had come up with anything that could help us.
I think on the financial side, the two areas that they're quite keen to understand with us, one particularly around plan care, we'll come back to that later in terms of is understanding kind of our issues in more detail, so they understand what is the opportunities of efficiency that we're working on versus what would require a place. And that was on the back of as well the fact that I feel that we haven't had a fair share of the plan care funding. So that's something that we will have a productive conversation. They were quite keen to have a open, transparent discussion and understand our issues on that. So I thought that was really helpful. And the other piece is to refresh the work we've done on the Grange and our new model to understand the benefits we get from that versus what it's costing us. Recognising we're still trying to drive the opportunities. So that's another piece of work that I think they're quite keen to work with us on, to understand, I suppose what costs, how the new system is driving costs, but then what are the benefits of that alongside it. So they are the two really helpful, I think, pieces of work that came out of the meeting that they're keen to work with us on.
Well, that certainly has been the latter point is something that the board has been keen to assess, so that there is a full understanding when we have discussions with them.
Yeah, and just to add to that, as Nicholas described it, the sort of next steps, I think it's positive for the board, because I've reported this previously, that there was positive feedback in terms of our annual plan was clear in terms of the cost drivers, the cost estimates, our underlying position. So I think the good news is that we can now all of us with Welsh Government focus on future rather than continuing to talk about the past. So that's a positive for us.
Good. Okay. Thank you. Can we move on to performance and outcomes then, please, Hannah?
Yes, thank you, Chair. So this is the probably the last format of this report you'll see as we move into the report against the new plan. So colleagues will be familiar with the setup for this. And we will be, as I just touched on, working with, we can see there's a suite following this item, and we've picked up finance and quality and safety and indeed some workforce measures that we'll be working together on to see if we can improve and align that performance reporting. In terms of the content of the report itself, I'll just draw out a few areas and then I'll have any questions. So there has been, I think it's fair to say, variable progress continues against the ministerial priorities and our key deliverables. I just want to draw out some positives before just sharing some updates on some of the challenged areas. In terms of delivering CAM, so children, adolescent mental health services, our choice referrals, that's meeting the standard, well, exceeding the standard of 80%, that's delivered 100% at the end of March 24. That was, we were at 87.5% in December 23, so already in a good position, but progress continues there. We've seen really positive progress in terms of patients waiting for diagnostics, and as we know, access to diagnostics is really key part of planned care journeys, but also a critical part in the pathway for patients on urgent suspected cancers. So in terms of balancing that demand. So the standard, as you'll know, is for patients shouldn't be waiting longer than 8 weeks. Pleased to report that from a position of just under 1,900 in November 23, patients waiting over 8 weeks for an endoscopy, That was down to just over 1,300 in March 24. I'm pleased to say that's come down again in recent April information to just under 1,300. So huge progress there. And similarly, we see the same improvements in radiology. That was at around 3,800 patients waiting over 8 weeks in November 23. And in April, that will be down to under 1,000, so around 964. So huge efforts by teams to manage clinical priority and access standards. In terms of progress against one of the ministerial priorities around extreme long waits, so 156 weeks, which is 3 years. At the beginning of last financial year, so April 23, we had 642 patients waiting over 3 years, and that was down to 31 for all parts of pathways at the end of March 24. So huge progress, and as you'll recall, as part of our plan, we've committed to completely eliminate and sustain that position. And I know it's a challenged area. We'll come on to it under the 6 goals update, and we've talked about it in the context of escalation, but I think important to note improvements in ambulance handovers of over an hour. So from a position of down from just over 1,500 in January of this year to around 1,100 in March. So loads more to do, we know, but it's important to acknowledge those progress areas. In terms of some of the challenge areas, it will be familiar to the board members in terms of the performance against the adult mental health standards, compliance against these standards. So in line with the Mental Health Act, the 1A, which relates to assessment, that's at 6% at the end of March against an 80%. So clearly challenges there. Pleased to report it will increase to 19% in April and should be around 29% in May. So green shoots of progress, but still a lot to do and a lot underway within teams, both from a technical validation and a process and pathway change. Similarly, the standard 1B, so once you had your assessment, you need your intervention. That remains at a disappointing level around 6.9% March and will be 6.7% in April. I want to give the board members assurance that this is a priority for the execs. We had a deep dive on it in our performance overview session last week, testing the actions in place, as I said, both technical validation, standards around reporting to bring them in line with sort of the surgical and the planned care specialties and how they're managed. But as I said, there are green shoots of improvement there. So under the time to be assessed, the average wait, so the standard is 80% within 28 days, but the average wait has gone down from 73 days in October down to 20 days in April. So huge progress, but still lots to do. Another area of challenge is, which I did draw out last time, but just to note, is the growth in their total waiting list. We'll come on in a later agenda item to look at actions and expectations around planned care. But the number of patients waiting over 104 weeks, or waiting over 2 years, at the beginning of last financial year was 3,383, and that crept up to 4,120 by the end of the year, largely driven by growth in outpatients. So they were some of the challenged areas that we continue to focus on within Leanne does within her team, but also us as execs. In terms of some progress against the wider set of deliverables, so more some of the strategic or service changes. Again, I'm sure we'll pick up it in the 6 goals update, but the acute frailty response team was launched with substantive recruitment underway. In the last quarter, the YYF, the Ysbyty Ystad Breast Centre, opened in February. Health Pathways was launched in April, so 50 live pathways, a key part of our transformation of planned care programme. So we will now be moving into that phase 2, the targeted pathways, but also the tracking of the impact. I think there's already a request for a more detailed session in the future briefing. So I'll pause there, having just drawn out a few areas, but happy myself, or I'm sure other colleagues will take any questions.
Thank you, Helen. Are there any questions, Paul?
Can I ask what's the issue with the mental health assessments? Because the time frames got particularly worrying.
Do you want to pick that up?
I don't know where to start. We've obviously had an ongoing issue with WCCIS, which has significantly impacted on our ability to access sort of robust data, I think, to inform where we have been from a performance perspective. We've done a lot of work with the team looking at the pathways and the models in particular of delivery, how long the assessment takes, how that benchmarks to other places, Paul. So it's a perfect storm, really. Our inability to report on the standards that are set out from a service delivery perspective. The operational impact that that's had on teams is not insignificant either. It's pretty extreme. I know Paul has spent some time actually with the teams understanding the operational impact that system has had on the teams. And then we have, in my view, a very traditional model of delivery on assessment. So the benchmark and the reach out to other parts of the country that we have done on that initial assessment process means that we're now piloting a different approach that will deliver improvement benefit. And positively, I can report and hopefully that with the work that we are doing at the moment for resubmission trajectories, we believe that we will deliver on the targets that have been set out specifically for mental health by the Minister in line with the December sort of target that's been set for us. So whilst the performance has been dire, we are on an improving trajectory, and we believe we will deliver the standards that have been set for us. And then we
could I follow that up? In the age profile issue, so they're more aligned to the young people or the elderly?
WCCIS has impacted on both sort of elements of service delivery, but the issues are very different in adult versus CAMS, for which we have very bespoke solutions. Our CAMS issue actually is a backlog issue in particular. So we're currently working through the backlog from the work that we've done, but the mental health, because of the integrity of the data, that validation process that Hannah alluded to is really, really important. So we get a clear guide on whether this is a recurrent issue or just a backlog clearance for us. Okay. Albeit we are seeing pressure on, I think, mental health services across the piece. David and then Paul.
Thanks. Are we in a position yet to be able to sort of quantify the amount of damage to our service that's been done by WCIS? We've been talking about problems with WCIS now for my entire duration of being on the being a member of the health board, and we've had one problem after another with it. I know we're intending on taking a different path with that in the future, but I'm really keen that we find a way of quantifying the amount of damage this particular service has caused us. I'd like to be able to understand the real impact it's had. So a lot of what we had so far has been anecdotal, but I'd really like us to have a look at how we can quantify the real impact that WCIS has had on our ability to deliver services, because I think it's really important we keep track of that and are able to report that in a very measured way.
I'm sure Paul will want to comment, but I've got a very specific example at the moment, David, of a 9-day referral backlog. We've got 3 whole-time equivalent admin members of staff trying to navigate a very difficult system to just upload the referrals even before we start processing them. So we have, I believe, pockets where we would be able to quantify that. We've not done that systematically, I think, across the whole system. As I said, I know Paul has done sort of more detailed work with the team sitting alongside them. I think we could do that, but we see it regularly, and I think that 3 whole-time equivalent admin members of staff is just a drop in the ocean in relation to the impact that that's had for us. Paul?
Yeah, just a few comments then. So just on Paul's comments, we've got some fixes going into WCCIS next month, which will improve some of the reporting that's currently being undertaken. On the short-term perspective, we are working with mental health services on a service improvement programme, looking at how we can address some of the issues in WCCIS around the referral processes, for example. So that's work ongoing. From a more medium-term perspective, we're making good progress on the requirements and the associated business placement of WCCIS. I'm happy to bring an update to that at the next board meeting. So yeah, I think progress is being made. appreciate the concerns of the service. If David remembered, we did bring a high-level report on the impact to a previous committee meeting, but I'm happy to ask the team to do maybe a bit of a deep dive on that to get some more information, and I can share that with the board.
Thank you, Paul.
Yeah, I think I would definitely. I think it would be really helpful for us as a board to get a really clear understanding of both the sort of the anecdotal evidence that we've had, because that's really useful to understand the impact it's having in terms of delays in care, the delays we're seeing in terms of staff morale and the problems that staff are having, but having some quant analysis on that to help us really understand the impact that it is created across the board in our mental health services, I think would be very, very helpful to be able to allow us to report back to the national organisations in terms of the impact that service is having, to try and help make sure that services like this that are developed and built don't fall into the same trap in future. And we need to be able to make sure we can feed that in properly, and into things such as the national Audit Wales on report next year in terms of digital system development. So I think it'd be really important to be able to feed that into those.
Thank you. Nicola? Yeah, and thanks, David and Paul as well. I think it is important that we capture the operational impact this has had. I just wanted to kind of explain the way the measures work, and our performance is so bad on the, the 0% up to 10%. Is it's really important for us to monitor performance alongside backlog. So when we've got a significant backlog of patients, when some of these have got 500 patients who are waiting over 28 days, and what the progress we really have made is the average wait for, I think, the Part A adults was around 73 days. It's now down to 32 days, but you're still not hitting the 28 days. So as you clear the backlog, you only count them at the point they treated. So everyone you treat this month, if not all of them have waited 28 days, you will have 0%. In a way, you could achieve 80% if we treated everybody out to turn and treated all the new ones that come in and ignored this huge backlog of patients. So for us, monitoring the backlog alongside our in-month performance is really important. So if you can see 500 people is now coming down to our trajectory shows that we'll clear the backlog. So there's only 10 patients waiting over that time. Then you start hitting your in-month performance quite quickly. So it is something we'll make sure that we share with you.
That's helpful.
But because you only you manage, you report on the patients you've seen. In fact, we do in 0% shows we are treating all those long waiters. And the data that we've got that sits behind it shows that our backlog is coming down, and the average wait, the amount of people waiting more than 56 days is dramatically reduced. But whilst you're clearing that backlog, you will be hitting 0%. And in effect, if we were delivering a higher than that percent, it suggests we're treating out of turn, or there is an urgent need for us to treat those patients. So I just wanted to explain that kind of narrative, because it's very easy to look at, and it's the same with cancer. We could treat every new referral, make sure all of those, so everyone we treated in month hit the 62 days, but we could have 300 patients who are waiting longer than that. So if you look at your performance in isolation, then it doesn't give you the true story, which you've got to understand your backlog alongside it. So I just wanted to explain that, because we often just look at the one metric and it doesn't tell the story of what's happening behind.
No, that's helpful, thank you.
Nicola, just a further point on that. These performance improvements are obviously good news. And since performance is often underpinned by staff morale and motivation, and I know the execs are spending a lot more time now actually on the shop floor, so to speak. Is there anything that we can see in terms of the sort of overall picture with regard to staff morale? And I would hope that these performance improvements are actually giving them a little bit of buoyancy.
I think the staff survey is our kind of best intelligence, as well as obviously our walkabouts and the intel you get, the small snapshots, and even the staff survey is still a relatively small snapshot, but it's trying to take and say that consider a combination of our intelligence to form a view of, but improving performance and being able to see patients more quickly will inevitably have a positive impact on the workforce. But then you're getting that balance between the amount of pressure we put on the staff and what we'd expect them to deliver. Again, it's that fine balance that each service needs to take.
Was there any further comment? Yes, please.
Yeah, on the back of the similar question to what Neil was asking, but I mean, I suppose from a positive perspective, because staff actually highlighted how difficult these systems were to work and how much they were causing issues within their working day. It's good that that was listened to and taken on board, because it's not always, in my experience, but this, from that perspective, it has been this time. How much are staff informed about how far we are on this journey? But since damage, I don't know whether or not they would be fully informed that there might be light at the end of the tunnel that would be about the system for them to be able to work with. Yes.
Yeah, we're working with the service at the moment. We've got a formal governance structure in place. We have regular stakeholder engagement sessions with mental health services, so they're aware that it is light at the end of the tunnel.
Can I ask one other question? It might be slightly naive. Why do they have a completely different system to the rest of us? Why aren't they all in line using the same system?
That's a good question, Louise.
Because I've never understood that.
So one of the pieces of work that we've got ongoing at the moment is a piece of strategic work looking at the future of an electronic health and care record for an Iron Bevan, and I'll be bringing that back to the board just after the summer, basically, which will look at some of those issues and options going forward. So there's a number of options now. We could buy a large integrated system that you often see in NHS England, which have quite a large price tag, or you could adopt a best of breed approach where we take the best maternity system, where we take the best critical care system, and then we integrate them together to provide that single patient record. So that piece of strategic work we're undertaking at the moment is looking at all those options, and then we bring them back for discussion.
Well, that would be good. And I think some of this also links in with our bereavement talk that we had earlier, because we've got two different systems. You can be making phone calls to patients that you actually, and I've been in that position because our data that we use doesn't indicate that that particular person has passed away, and they've made an unfortunate phone call to the family, and it's very embarrassing and very upsetting for them on the other end as well. So to not have these, because if people are not talking to each other, because communication is part of that as well, and everybody hasn't got time always to update another service that they generally link in with, but we might not be attached to the mental health division under that. So it's yeah. Thank you.
Thank you. Are there any further questions? No? Thank you for that. 4.3, patient safety and quality.
Thank you, Anne. This paper clearly it's our second or third iteration to the board. So this is our quality outcomes framework, which has been a joined together of work for myself, Peter and James, really focusing on how we meet our duty of quality and candour, but also how we ensure that we are, as a board, cited on the issues of patient safety and quality. You'll know that we've continued to develop this framework. So the framework we had in place the end of last year has developed significantly, and we're about to go through a second iteration of the quality outcomes framework, really trying to see where we can automate measures, start to focus on the meaningful measures, how we link that with Hannah and the plan care and the finance and workforce reports. So further work to be done in terms of bringing together a cohesive outcomes framework, but also looking to support our staff with some of the automation of the data. And thank you to Paul and Hannah's team who've been supporting us with that work. Long way to go, but we are definitely ahead of the rest of Wales. So this is a quality lens. So there is performance data included, just to point that out, but this is about the quality lens of the performance data, and we'll continue to hone how we make sure the reporting focuses on the quality elements. Some positive things really to talk about. So we have approved through PQSOC our first listening and learning framework. So that's really pivotal in terms of really starting to get underneath how we learn from incidents, how we prevent recurrence, and how we reduce harm. So it's the first framework for the Health Board. I think it's the first framework in Wales. I think CTM went first, I should say. But, you know, a real opportunity to draw people together around our systems for living and how we focus on harm. Over the last quarter and through the year, we've seen improvements on RAMI. and the Health Board have seen improvements in our crude mortality, but also we've, as Nicola has said, we've focused on our learning from deaths approach. So really starting to think about how we turn mortality indicators into something meaningful around learning from when deaths occur. There's not always learning, but there is in some cases, and we've used the English framework, which has been in place for some time. As Nicola said, we launched the PAL service in November. We have around 700 referrals a month. Those would otherwise have ended up with ward staff or ended up in the formal complaints process. We still need to think about how we consider the service will support PTR, particularly around our grade 1 and grade 2 complaints, but that's work in progress. We've done a huge amount of work this year on human factors. We've had no new Never event since November. We know that behind every patient safety issue is a human factors element and a system and process error. It is rare that human error occurs without system and process error behind it. So, huge work focused on human factors, and PQSOC will receive a detailed report at its next meeting on the work that's happening across the Health Board. We've had a renewed focus on clinical audit, strengthening reporting governance, and we've improved uptake of safeguarding level 1 and level 2 training. We've also improved our health and safety assurance, and we've also had a number of quality improvement projects which have been nationally recognised. James and I attended the Safe Care Collaborative to talk about our QI journey and experience, because we're seen to be leading in Wales, but also some of the specific projects have been shared on a national stage, focusing on deteriorating patient and the work that Neville Hall have been doing on pulling patients back to the community with Monmouthshire. We also have a number of QI collaboratives that are running. So we have one on hospital-acquired pressure ulcers, and we also have focus on deteriorating patients and C. difficile, which, as you know, is an issue. In terms of areas of focus where we have concerns, risks or issues, we've summarised those within the paper for your consideration. We have seen infection rates for C. difficile rise over the last 12 months. We also have seen a rise in gram-negative infections. Moira, my head of IPC, did a detailed report for the exec committee last week, and we'll bring a paper back on gram-negative infections, which will go forward to PQSOC. When you look at the data, we are below the Wales average on every single infection indicator, but that's not to say we don't need to improve, because we are breaching the targets that have been set by Welsh Government. So we have a C. difficile improvement collaborative. James has met with my team to focus on how we can focus on particularly the pharmacy, the polypharmacy issues and the antimicrobial prescribing, both of which are areas that we really need to do detailed pieces of work on, and to refresh basic good IPC practice. With the use of PPE in the pandemic, we've lost some of the basics. So it's, as ever, back to getting the brilliant basics in place and getting back to doing the good IPC practice. We've continued our focus on quality of care within mental health and LD. And we, as you'll know, we've reported on the 30, 60, 90-day improvement plan, but work continues on quality improvement, safety improvement, and working and engaging with staff in those improvements. We've also focused on quality outcomes and timeliness of care within urgent care. We know that when patients wait within ED or wait on the back of ambulances, harm can occur. Sorry, can get the occur right. And we've been supporting Leanne with the work to improve urgent care experience and safety. We have seen variation in our falls performance. The data is variable. And in Q4, we did receive a regulation 28 from the coroner in relation to an inpatient fall, which I know the board is briefed on. But we are continuing to focus on our falls performance and looking at ways in which we can improve care at the front line, which is really where we need to focus in terms of, again, getting some of the basics of care back in place, good documentation, good risk assessment. And when we do assess a risk, making sure we put in the mitigating measures and that those are monitored. Safeguarding level 3, whilst we've improved in level 2, safeguarding level 3 training remains a concern. And again, we're trying to think of new and innovative ways of putting that training into place for different departments. One of the issues is some board members will be aware of. There's a UK-wide intercollegiate document which really specifies the requirements of the training, which includes an element of multi-agency and an element of face-to-face. So it's how we do that in a way that supports our frontline staff to join that training. And finally, the thing that I don't think I can ignore is the putting things right compliance. In the same way with some of our performance targets, by focusing on the backlog, we absolutely don't address the performance within 30 days because we're focusing on the aged complaints, so we do need to keep an eye on both. We have seen a steady improvement in our over 12 months, but not good enough. And we know we need to focus, and we are planning to we have put in place a trajectory to be compliant with 70%, 75% of fixed load concerns closed within 30 days by October. The team are working very hard, but it is quite a hill to climb, bearing in mind that we do have around 600 complaints a month. So we're not talking small numbers. And I think PALS are pivotal now. They've been in 3 or 4 months to really try to help us do that. Over the next year, we're going to be really focusing on our pillars of quality, and those are reported in our quality strategy, being really clear on our objectives for quality. We're really going to focus on our board to floor connections, particularly our governance. We have ward and team accreditation coming online this year, which will start to look at how we have that golden line of performance monitoring right from board and team level through to what we report to, ward and team level through what we report to board. And that's it from me, Anne.
Thank you very much, Jenny. Are there any questions, Jenny?
Louise, only one. With regards to the pillars, it doesn't actually mention families, but mentions patients. Are we thinking of including that? Because I wonder if some of these complaints have become is the lack of communication we actually have with families rather than with the patients, and whether or not we're taking that on board.
Yeah, so if you refer to our patient experience and involvement strategy, it very much talks about families, very much talks about what matters to me, and that's a family perspective, and communities and the public. You know, we are starting to talk in terms of, you know, how do we respond from an experience perspective to the wider community, to the public who access our services. So, you know, very much part of the work we'll do. And you're absolutely right, as I referred to earlier when Gemma was talking, we are going to put in place communication standards for families and patients. And sometimes it's a patient that complains, sometimes it's a family, sometimes it's both. And I'd expect those communications to be going on a regular basis. You know, sometimes Nicola and I will pick up a complaint, but perhaps there hasn't been any communication for months, and that's just not right or appropriate. So absolutely, Louise, families are absolutely embedded within it.
Any further questions, Louise? I think it's quite right to keep a relentless focus on these very, very key areas. It makes such a difference to the outcomes for patients. So, you know, we look forward to seeing them improving over the next few months. Can we then go to the nurse staffing level act report?
Thank you, Chair. I would say most of this is read. Just to highlight, this is our annual report, and it obviously comes for assurance. We've detailed within the report the recalculations that have been done. As you know, I meet with every divisional and the ward, every divisional ward around the recalculations. There is no request for additional financial funding within this annual report, and is for assurance only.
Thank you.
And just to say that you will have received, and I will have received, the report from the Health and Social Care Select Committee on the revisions to the Act.
Yes.
I think it doesn't go as far as perhaps we thought it might have done, but it's helpful in other aspects. There won't be any extension to the Act, but we will have the Act remaining in place.
Yes. So a minor advantage. Yeah. Fine. Any comments? No, I think it's very clear. You do report it thoroughly and frequently to us, because we are held to account for this. Okay. 4.5 to 6 goals for urgent and emergency care.
So thank you, Chair. So this paper sets out the progress over the last financial year and our priorities for this year in the 6 goals programme. As you know, it's quite a broad programme of work, and what we've tried to do within last year and this year is really start to focus on the areas of work that will really make a difference to patients and to the experience and outcomes for our service users. We've consolidated it into 3 overarching work streams. Each overarching work stream has an SRO and also has an executive sponsor, and that's myself, James and Peter. So James is focused on goal 1, Peter on 2, 3 and 4 with Paul Underwood, and discharge improvement is now Mandy Hell with myself. Just in terms of, if I just canter through the goals, and I'll just highlight a few areas in each of the goals where I'd really like to bring to the board's attention the work that's been done. So we've had the nurse-led acute frailty response service. We clearly piloted that from the 22nd of January. As you'll see from some of the data within the paper, it can't be attributed to the acute frailty response team alone, but clearly there are improvements that we are making in terms of admission of older and frail people to our hospitals, which we know quite often, for some people it is right to be admitted, for others it clearly is, you know, there are risks from falls, infection, pressure ulcers, etc. So the nurse-led acute frailty response service is now mobilising 7 days a week. We've appointed our nurse consultant for frailty, who's Zoe Carter, who presented a board a while ago on nurse-led wards at YAB. We're very pleased with Zoe's appointment, and we're really looking forward to seeing that service embed on a 7-day model and start to make a difference, working collaboratively with the CAT and the extension that's been agreed to the front door therapies model, but also Home First as well. So really a focus on how we avoid unnecessary admissions for older and frail people. And when we say frail people, we mean younger people with comorbidities as well. So this isn't just about older people. We've got a phase 1 pilot in place around a professional hub. So this is building on the flow centre model, but looking at the addition of a CRT clinician within there to identify, again, as the calls come through from the ambulance service, how do we redirect those people into our CRT services. We've focused on our high-risk adults, certainly within older and frail people, and I'm going to be doing a bit of work for Leanne, really focusing on how we have a comprehensive model for the high-risk adult cohort. We know there is an element of that where frailty is a feature, but we also know there's more we can do in terms of case finding and proactive future care planning for those individuals. So phase 1 and phase 2 for the frailty element of that is in place. We're looking at how we broaden that wider within the programme. So goals 2, 3 and 4. So this is a big programme of work. As you'll know, it works across in terms of the work we have in place with the urgent care escalations, but some really pleasing work in terms of single system navigation, looking at single phone numbers, progress on same-day emergency care, and increasing certainly our medical admissions to the SDEC, but really pleasing progress on surgical admissions. We put in place a new falls pathway with the service, so looking at how we redirect patients who have had a fall, who may be frail and elderly, to our ELGHs, and we don't bring those patients to ED. I'm pleased to say that that's made really positive progress, with 47% of patients with injurious falls being conveyed to an ELGH with, I think, James, no concerns around patient safety at all. There was a concern about whether we'd have lots of steps up, but that's not been the case. We've had a very detailed collaborative with WAST as well. We've had some external support from an international improvement expert, and we've been working with WAST to look at how we reduce conveyances. We had a workshop in March, and there'll be a further workshop planned for October, but really starting to focus on how we work collaboratively with WAST, particularly about those conditions that they see through our triage process, which are sensitive to an alternative, those being chest pain, respiratory, and obviously frail and elderly. But really starting to look at how we also focus on the own transport referrals, because those come into sometimes the hear and treat numbers, but clearly they're not what I would call true hear and treat. but focusing on, are those patients ending up in ED, or can they be redirected by a UPC or 111 service? And the final thing for goals 2, 3, 4 I'd like to mention is just the work with urgent primary care, really looking at how we pull patients from the 111 stack into our UPC centres and trying to make sure that we are reducing demand again on the 111 999 service, but an appropriate response in terms of the urgent primary care. Goals 5 and 6. We've had 20 patient safety team interventions across all sites, and we are seeing some chinks after those events of improvements in our length of stay, but also our delayed discharges. We're about to launch our new discharge lounge at RGH. That's moving up to the 6th floor. It's a brand new repurposed ward area, and we're working on a model for the discharge lounge built from a model that we saw in Somerset, where they really focus on a pool model and getting patients from the wards 8 o'clock in the morning after breakfast, so they don't get reassessed. So they're on the discharge lounge. We can sort out their TTOs. We can sort out any further arrangements that need to be made and make sure those patients get home before the end of the day. It's really effective in Somerset, and we've looked to replicate that model. We've also launched the Ready to Go unit. In some ways, this is not a unit you would absolutely want, but certainly something that we feel we need, certainly for the interim. So the Ready to Go unit focuses on those patients who are optimised for discharge. So those patients who may be waiting a care package, they will be therapy optimised. So it will be a ward that has it has less RNs, it has no therapy input. So it's really for those patients who are optimised for discharge. The idea and the model is built on the fact that we will try to mirror the care they will receive in the home environment. So we will not intervene with them on a regular basis. We won't do regular obs. It will be trying to mirror that arrangement. But early days, we need to do more in terms of the pool, but absolutely, really sound development. Finally, the only two other things I'd mention in goals 5 and 6 really are our hospital to home initiative. So we've had some BRIF funding that was agreed last August. This is a early supported discharge model. Again, it's built on some models we've seen across the UK, but really focusing on pulling those patients back to the community so they can be assessed in their own home, and putting in place wraparound care. I'd have to say we've had, I think, differing levels of support from our social care colleagues for this model, but we've had agreement that we will pilot this in Monmouthshire and roll out to Torvine likely next in terms of next steps. But there's a really pleasing patient story where they took a patient home, and actually he has ended up with no care package at all because he's been supported in the home environment. So it's some really pleasing work around early supported discharge, which we want to roll out, but need to get some evidence base behind us in terms of what that looks and feels like. And finally, I cannot end goals 5 and 6 without talking about Move It May. So many of you will know in England, they did a focus on ending PJ paralysis. We called it Move It May. Leanne and I resisted the song that goes with it. Please stop the song.
We need to do a TikTok.
But, it's really, really important that we focus on getting patients up, not languishing them in bed, getting them dressed, getting them moving, getting them off the trolley, going to the toilets, removing that deconditioning, and really focusing on enabling them rather than treating them as a patient in a bed. So really, really important. One of our senior nurses at RGH has spoken on a national stage across the UK about this because people are so impressed with the campaign and the work that they've done. So massively important in terms of a culture change for deconditioning. And really pleasing that, we're leading the way again in terms of what that looks like. We've obviously put in the anticipated programme benefits. We've put into place our priorities for next year, but I've pretty much talked about those because they're a continuation and an evaluation of the work that's been done. The only one I'll really highlight is that we're about to do a pilot with WAST. It's based on Lucy technology. Don't ask me what that is, but it is a It's an IT system that will enable remote monitoring in the home for patients who are waiting an ambulance response. We'll do that collaboratively, so we may well be able to respond to those patients and avoid an admission. So it's an admission avoidance piece of work. It's not a true virtual ward, and virtual wards is something that we want to develop over time, but it is a starter, certainly for those patients who are waiting an ambulance response. I'll pause there.
Thank you, Jenny. That was really, really helpful. And it's very pleasing to see the progress that has been made, particularly on the frailty side, where there are some really good schemes now coming to fruition within Gwent. Thank you. Pippa?
Yeah, I wanted to, I will echo what Anne said in terms of the progress that you've made. I think has been excellent, and in some cases just been, exceptional. And I feel it's absolutely everything's moving in the right direction. I have one question that was which you haven't answered, and it's about the e-triage. So obviously you've started the e-triage, you've stopped it for an issue that I wasn't quite certain what it was, and it says it's going to be reintroduced in Q1. And I'm kind of thinking we're in Q1, so I wondered if you could give us any kind of
Yeah, it's being relaunched on the 10th of June.
Right.
Yeah, so that the suppliers fixed the software bug that caused the issue, so we're relaunching on the 10th of June.
Okay, so this wasn't an issue for us using it and it being a problem. It was an issue in terms of the software development that meant we couldn't use it the way we wanted.
Correct. Yeah, it caused an issue that the supplier had before the safety use.
Yeah. And I have felt to say that I just want to say a thank you to Leanne's operational teams who have been exceptional in this work, along with my directorate James's and Peter's, because we couldn't deliver this programme without that. And I think this is very much a collaborative programme of work with across divisions, across directorates. It's no particular division, and people have come together really well in that space. But I just want to say a massive thank you to Paul, because one of the issues with our data around discharge is that some of the information we have, there are data quality issues. So when you see a list of medically fit patients at any one time, there's probably about 2/3 that aren't medically fit, but there'll be another third that is. And we also have issues around the coding of things like social care delays versus our delays. So Paul's going to help us to put in place a solution. It won't be quick. And we've got a starter with something called CWS2, which will help us with D2RA and red to green. But we really want to refresh, revise, put in place a data system that will enable us to accurately understand where all patients are at any one time, and really start to focus on, therefore, how do we get behind the actions? Because to be fair to the local authorities, yes, we do have social work delays and care package delays. Some of the data isn't quite reflective of the current position. So there is a lot of work to be done in that space.
Thank you. Helen and then Louise.
Thank you very much, Jenny, for the update, and great to see progress on various things. Just a quick question on the patient safety events that were obviously very helpful. I wondered, are those continuing regarding discharge planning, or are we hoping that the lessons learned and the principles are now embedded in the team, so you don't need such large events so regularly?
We will continue with them, in part because clearly we have a need to ensure that when we're in escalation, our system works as effectively as it can do, and we know that the patient safety events are very effective in driving forward, in particular, discharge and the care pathways for patients. The one thing I'd say is that there's a lot of work nationally in the deconditioning space around culture. And I think one of the things we need to ensure we do is to, when we're picking up the recommendations from the patient safety events, that we really focus on how do we take the learning back into those very staff who we need to be the change. So particularly our ward managers, particularly our consultants, our therapists on the wards, because actually it is them who can make the biggest difference. So we need to make sure we're engaging with them. We're already doing some work with some wards at RGH around how we do that. But really, you know, if I go back to when I was on a ward, I knew every discharge date for the patients I was responsible for. I would manage and draw together people around the patient to make sure we process that patient through their pathway. So they're really, really good at processing and really, really good at helping us with, you know, when we're in escalation or, you know, some of the work we need to do around St Woollers moves. But actually, we need to also focus on the culture and practice change we need. So there's a two-stage process with it, Helen, really.
Thanks very much, Jenny. Thank you.
You want to add something, Leanne?
Partly on that point, and just one other sort of very quick thing. I think we've made the discharge environment incredibly complex. And, you know, one area of opportunity, we talked about links in part with the financial sort of conversation. We have across Gwent £1.7 million worth of investment of staff dedicated to complex discharge that have different job descriptions, different roles, responsibilities, that is different by individual localities. So some of this is structural change, but we've disempowered, I would entirely agree with Jen, the teams to do what's their core role. I think there are some things we need to feed in from a national perspective. Complex discharge planning, for example, doesn't feature in any training programme for any of our healthcare professionals. So I think them understanding that forming part of the cultural piece is really, really important. So I think that's a massive opportunity for us. And just a quick point across the broader programme of work, hugely grateful for Jen supporting the high-risk adult cohort programme, because in terms of materiality, about 2% of our patient population accounts for half of our emergency medical take. So I think if we can do something on a more proactive basis, you know, really honing down on the patients that require the most sort of from us, then I think we've got an opportunity to take that out of the hospital setting, which we have a huge aspiration for and we know is the right thing to do, into the community and primary care in particular, and wider community in terms of that support. So I think just to flag that focus for the coming year as well.
Good. Huge opportunities for that, I think. Yeah, good. And the issue about the complex discharge is actually reflected on a national level. You know, I attended a national roundtable a few weeks ago, and it was pretty much the conversation from everybody. That, you know, that we've overcomplicated processes as a system, you know, as a wider Wales-wide system.
Thank you, Louise.
Yeah, thank you, Anne. Acknowledge all the good work that's gone on, and I think it's great, and we're moving in the right direction, aren't we? So these very simple questions, you'll be pleased to hear. As regards to the force redirection, have we seen a fall in the waiting ambulances at the front door? Have we seen an impact on that change yet?
No, I don't believe it's changed the number.
Not one attributable to that, but it's part of an overall strategy. The best way of avoiding ambulance wait is having people coming nowhere near the front door of the Grange. We try to hold them in their own home or an ambulatory clinic or via their GP or it's an ELGH site. So that going to GUH is there for the people who need to be there. So that sort of process control chart we've shown of, you know, the number of elderly admitted, good would be 100%, because it means every single person who turns up at the Grange really needed to be there and really needed to be in a bed. But we also want to make sure that, you know, our highly specialist centre is being used for highly specialist work, and the ED clinicians brought to us that approximately 90 people a week were coming up to the Grange with non-injurious falls, of whom 1 or 2 would have a hip fracture. And I brought together community teams, the LGH teams and the ED teams to talk about their approach to those patients. And it was very insightful because, in particular, I don't think the ED team realised just how much our community teams do, and were surprised that they did some of the assessments in patients' own home. And we made a risk-based decision not to do an extensive consultation. We got the right people in the room, decided whether the process was safe, and then we just started it. And there were quite a lot of concern raised by clinicians, which I'm really pleased did not come to fruition. I think we've had 3 step-ups in 6 months, but actually I pointed out that's what the system's designed for. The system is meant to be a step-up system. In fact, it's a step-down system.
Well, I'm delighted to see that somebody's actually got to grips with that, and we haven't got 4 unfortunate people going all the way to the Grange and sitting there waiting. So that's a bonus. My last question is about the Move It May. How are we monitoring that that is being carried out continually throughout the year? Because we can have a campaign just for May, which is great, but how are we making sure that staff are always compliant to that level? And have we got the space capacity to be able to actually do that? Have we got the space to put the extra chairs in, and all the extra things that come with the Move It May campaign?
So it's difficult to evaluate, but I have spoken to Linda, who's for discharge, on how we might do that. And we've also reflected we want more than a Move It May. It was great to have that. It was a real splurge of activity and energy around an issue. What we need to do is almost have a Move It every month.
Needs to be the norm, doesn't
it? Needs to be the norm. So we need to think about how we take that programme forward over this year, because we've got some really great clinical leaders who are really energised by it. You know, they're really energised by this. I think day room space is an issue, particularly in a pressurised system. You know, we have tried to protect the day rooms, in particular in community hospitals. You know, we're trying to ensure that Ready to Go, for example, doesn't currently have a day room, but working on a plan to give them a day room so they've got that space to do meaningful activities. And the other thing to say is that we know that my team have just done a big review of enhanced care and meaningful activities. And actually, we know that if we put into place meaningful activities, different ways of interacting with patients, we're likely to get less falls. We're likely to get less, less delirium. So I think there's some real opportunities in switching our thinking, which everybody, we've had immense support to do this, but there's almost holding our nerve on things like not boarding in day rooms to enable us to do this work with patients. So, I think it is about creating the space and the availability. We also need to make sure that when we have coordinators now across the health board who do meaningful activities, they will do something different. So again, what's our approach? Should we standardise that? And I think that's again something we need to do. So yeah, absolutely, completely agree. It needs to be Move It January, February, March, April, May.
Yeah, and we've got I know this is a very simple question, but we've got enough chairs by the beds and then chairs in the day rooms for our patients, or are we having to move things to be able to get?
I haven't done an audit, but I think certainly in our community hospital spaces, yes. And I've just done a piece of work with Leanne's team around following the move of the St Wallace wards, creating more space for them. Now they've moved. But I do think it's an issue in IQ environments because we don't have the same space. And there is an acute issue at YYF I think we need to have a look at. But we've got a fab meaningful activities coordinator up there who makes space. And she's got things on the walls, she's got all her equipment around, she draws patients to her, she's brilliant, and you almost want to bottle that and use that to expand.
Yeah.
Louise would join the TikTok now because she's very passionate about this.
Yeah, you want to join the TikTok?
Right.
The Move It May.
Oh God, Move It May, yeah.
That's a video platform.
I do know that.
Sorry, I was going to ask this question later on communication, but TikTok and being used in such a large organisation, is that wise? Because I know that other organisations are thinking very hard about it and some have banned it. So I'm just wondering, from the security point of view, I was just wondering, is it encouraged? Is it used? What is the feeling about it? I don't know about it. I'm just unbiased, but I don't use it, obviously.
I'm thinking on the fly here, but if you look at young people and where they source their information, an inordinate number obtain that information from TikTok. So it is a platform that you can use to access sections of the population who are traditionally hard to reach. And the onus that is on us is to ensure that the information that we post is clinically valid and reliable and doesn't breach any data governance or privacy rules.
Paul, and then you, and then David.
I was just going to say what James just said. So there is a new social media policy that's just been released for NHS Wales. And I think it's important we make sure that that message is out to the health board so people are aware of how we can safely use these platforms. As James said, a lot of young people, those are the platforms that they engage with now.
I'm
So-
much more worried about WhatsApp, actually. The way of clinicians communicating. I would much rather that was an in-house system. I mean,
Yeah.
I haven't wanted to ban it because sometimes clinicians here use it to communicate with clinicians and the health board. And as we've removed faxes, we've removed a way of timely real-time communication. It's a real headache. We almost need to make a technology leap. But when I can say goodbye to WhatsApp, and that's probably really pleased.
Yeah, but sorry, can I come back? It's from an international point of view, obviously, I mean, there are concerns about security. I'm not talking about, our own preferences, but I'm talking about security. But you don't think any of that would be breached? And you say that all the staff will be, you will inform all the staff, will you, about, advise them about
Yeah, we have
the policy?
we have an information governance structure in place. So we have divisional meetings from an information governance perspective with all the divisions, and we'll make sure that we communicate with that method so that any confidential information is never shared on these platforms. And just to come back to Jane, we'll be going out for procurement in about 6 weeks for a new clinical communications platform to the health board to hopefully wean people off WhatsApp.
Hang on, David, Karen and Louise, goodness me, we're not.
Okay. I mean, mostly just to sort of back up what James and Paul have said. From a security perspective, there are definitely some concerns around TikTok and other platforms, but that's mostly down to there's an element of that is political in terms of national politics, unlikely to be an issue for Naira and Bevan. But in general, we should aim to be where our patients are. And as long as we're not discussing individual patient safety or patient data on those platforms, we are almost certainly going to be okay. And that's the main thing, is as long as we're using it for sort of outbound communication rather than back and forth communication with patients, we will probably be in a good place. And we should aim to be where our patients are and use that as much as we can. So that's TikTok, that's Twitter, that's Facebook, and any other social media platforms where they might be.
Thank you. Karen?
Thank you, and I agree with everything that's been said. I just wanted to add a reassurance. Everything that we do on any of our platforms, we check, we keep an eye and make sure we have the policies, as Paul said, in place. TikTok is a new one for us, and it's one that we are building to engage with the younger generation who really do want to engage with us. And just as an example, we put a post out a couple of weeks ago and we had 345,000 views, and it was very educational, and the support was really good. It was one of our highest ever. So we are really cautious and careful, but it's one that we do want to progress for the right reasons, but taking into account the security around it. So it was more of a reassurance, really, Chair.
Thank you, Karen. Last word, okay.
It was just to reassure Penny that any national policies come through a process. So that they'll come to the policy group, even though just to ratify, and then it goes to exec. So from a staff side perspective, we're aware of the new policies, and from a perspective of partnership working, they are done in partnership with the trade unions and with Welsh Government and with the execs in all the health boards within Wales and the Welsh Partnership Forum.
Right, I won't ask it during community, so they will go past quickly. Thank you.
Thanks. Thank you very much. Okay. Might I suggest we have half-hour break and reconvene at 1:45, please?
Yeah.
Okay. Okay then. Welcome back to the meeting. Could we start with 4.6, the planned care programme, please, Anna?
Yes, thank you, Chair. I'll start with an overview, and I'm sure Diane will come in as well to provide some context. So this paper, an update on planned care, covering just recapping on what the stand policy position and targets the ministerial priorities are as they were known at the start of the financial year. Does give an overview of our Health Board planned care programme and its work streams. It just reminds us what we set out in the annual plan discussed at this board in March 24 in respect of performance ambitions against the planned care targets. And then it does set out what's been referred to a few times today, gives the background and the ask from Welsh Government within this financial year now in the ask around additional trajectories against planned care milestones and the actions we plan to take and are taking to respond to this. So just a few areas for me to pull out rather than some of the policy stuff. As I said, Nicola's already referred to it in her opening chief exec update. But page 6 of the report does set out the 5 themes against which Welsh Government like an update in terms of actions we're taking. Under each of these themes, they have a number of sort of high impact changes, some of which are already reflected in our plans, and others we just need to assess opportunity and impact. It also sets out on page 6 the new milestones associated with the ministerial priorities, with the planned care ones highlighted in yellow. Just important to note the actual sort of standards remain the same in terms of patients waiting over 52 weeks, 104 weeks, 8 weeks, etc. It's the milestones associated with those and the percentage delivery that has changed, and so that's highlighted on page 6. And then moving into sort of page 7 in the assessment section, this is where we set out a bit of a state of the nation really in terms of where we currently are in terms of activity. And it sets a context for the work we're doing now. So you'll see from that section, activity relating to first outpatient appointments has been back over pre-COVID levels. It's not quite there with treatments yet. And then in the detailed specialty analysis on the third page, you can see set out from COVID perspective and where we were last financial year in terms of activity taken by those high volume specialties under core resources, and then also the use of ad hoc, whether it be backfill or waiting list initiatives, and where we've outsourced. I think the key messages from this is that there is variation in terms of activity and the various ways it's being taken out by specialties. Overall, as I said already, the outpatients core activities increased but are decreased in those ad hoc sessions. Treatments, you can see again, it's not quite back up to the levels, and again you can see the variation between specialties in terms of performance or delivery from an activity perspective. Goes on then just to put that in the context of demand. We talk a lot about demand is increasing. Some information at the bottom of the page, going on to the next page in terms of by specialty, the demand into primary care. And again, with the exception of ENT, which is quite interesting, demand for planned care is going up in all those areas, but you know, a range of sort of, I think it was 14% in some areas, 104 if we include radiology. The paper just then goes on to just set out the next steps and the work that's already in train. The work we'd said as part of our planning discussion we were going to undertake on some of those really high challenged specialties, ENT, ophthalmology and orthopaedics. But now thinking with that, the work we are doing and the AMS team are doing really to respond to those updated trajectory milestones and our response to the actions and activities we're already taking and new activities we can undertake in response to those 5 themes and those high impact change areas. We have a session with the exec team tomorrow to go through where we are on those activities, to consider choices, opportunities, to help develop and find the response before the response needs to go back into Welsh Government 31st of May, which is a Friday, so the end of next week. So you share that's quite a high level of overview. Leanne, anything you want to add before we?
No, happy to answer any questions. No, I think you've covered it.
Thank you, John. Are there any questions? I'll start then. I think it's really important that we get sight very early of the planned improvement programme for the 3 specialties that we're having such problems in managing, particularly in the light of the growing workload in 2 of those, and the fact that one of those services, it really does seem to be struggling despite everybody's best efforts. So I think that it would be important that we have assurance on that. I think that it's a little unusual to have the targets changing a year into the new year. And therefore, obviously, I would expect you all to be calculating the art of the possible. But as you know, the Minister and the Cabinet Secretary is very keen on our being able to prove productivity is optimised, and we are certainly going to have to do some work on that, as she has been requesting. So I think there's a fair bit of work to be done to expose the rationale underlying these figures, so that we do get a concrete plan, and that we can be quite clear to everybody what we can and cannot achieve, especially if things move around a bit. And I know that there's a big push at the moment on fellow theatre lists and how they're calculated and all the rest of it. And I think to have a set of data which everybody can acknowledge is verified would be really important, because you get all sorts of figures coming out about the same thing, and they don't really correlate one with the other. Nicola.
Yeah, thank you. And I'll just add to the, obviously conversations are kind of ongoing and there's work ongoing as we speak, and Leanne's teams have been working exceptionally hard to try to pull together our choices. So just to kind of clarify where we are, I think diagnostic and cancer, in terms of some of the ask, we are some of it's in line with the trajectory and the ambitions we've set out what we can achieve. Diagnostics will be a bit of a push, but we're not far off. The tool that we are quite adrift from is the 52-week outpatients and the 104-week total treatments. As you know, we put a huge effort into reducing the 156 weeks, which was a top priority, and we've made significant progress. I think what is difficult is, as a health board, is both of those metrics don't even hold a position. They get worse in our trajectory for the new year, and we already identified as an area we wanted to do further work to try to improve on that. The 104 weeks is pretty much down to 3 specialties: TNO, orthopaedics, ophthalmology and ENT. There's a few extra specialties in the outpatient side of things, particularly neurology and max stats. So as we said, we're doing deep dives. We've also asked the divisions the art of the possible in terms of what would it take to clear this. Outpatients, to a certain extent, is potentially easier because you know it's a lower cost, high volume, and you can. But treatments is a much more bigger issue. So some of the things that we are doing is what more do we think we can do to demonstrate through an efficiency mechanism? So I think you know, making sure validation is really robust. What can we do through efficiency that doesn't cost us any more than we guess? And on an outpatient point of view, you can do that fairly no cost. What things are options for us that might need a small amount of investment that we possibly could accommodate within the existing financial plan, albeit we don't really want to commit more resource, we want to reduce it, versus what it would take to deliver the target. And I know Leanne and the team are working with, I don't think we've got a line of sight on that, and it could cost millions of pounds, because when you go into treatment and you go into orthopaedics, that is, you know, some of those cases are very expensive. reducing fallow lists, putting more patients through it will cost lots of money on a non-pay basis. So there's choices we will need to consider once we've got a clearer narrative. So that is kind of the work that we do in to try to understand it in those categories. I think we've got to be really clear on the efficiency opportunities in terms of how can we drive. There's a lot of focus on treat and turn, which we look at, but when you look at ophthalmology, orthopedics and ENT, all of them are out of balance on a recurrent basis. So the current demand and the current capacity are not in balance. And between those three specialties, I think at about 12,000 out on a recurrent basis. So we've not only got a backlog, we're not in a balance. Because if you're in balance going forward, you can just clear the backlog and then you're up and running. So we've got to, through demand management opportunities, alternative pathways, or increasing capacity through efficiency, look at how we can bridge that gap. And a big point to pull out of that is orthopedics in particular. Historically, we have delivered a lot of activity through core, but we've delivered a lot of activity through waiting list initiatives and kind of variable approaches. And we've stopped all the waiting list initiatives on the back of the financial position and sustainability, but that is a big contributor now to our recurrent shortfall we've got in orthopedics, hence why each of them has got a slightly different challenge. So that's what we're currently working through to try to look at what we can do with no or minimum resource and have high impact, particularly on outpatients. But I think when we get into the treatment areas of things, then there's a much greater challenge. And at this point, we have not got a line of sight of how we can deliver the Minister's targets. But it's about how far we can go. And I think as a minimum, if we could hold the position to last year as the first stage, and then what would it take to go beyond that? But and as I mentioned earlier, the escalation meeting with Welsh Government was helpful in that they were keen to understand some of our analysis around our planned care challenge, because there has been a view shared by colleagues in Welsh Government that this is deliverable within existing resources. We have not got that line of sight at all, but happy to be challenged on that and see the evidence that supports that we can then review. But recognising we need to come back and have further conversation at some point to inform the trajectories we've got to submit next week.
Thank you. Can I then ask? I note the comment that they want elective care to run 52 weeks a year, 7 days a week, 15 hours a day. Now, what is the potential for that?
Just thinking how I phrase this professionally, really. I mean, considering we've got a workforce shortfall on the basis of our current theatre utilisation, and a consideration particularly for unsocial hours working and weekend working, it increase our cost base on the basis of enhanced rates of pay as well. We don't have the workforce on the basis of the fallow lists that are being reported nationally to staff those theatres. It would be helpful if we even had a definition on fallow lists that we could all back. There's lots of clinical debate about that at the moment. So I don't know, I understand it as an aspiration, particularly set in the context of capital scarcity. But I think, the modelling, the workforce modelling, I think that underpins that, in my opinion, must be non-existent.
Even if we have the money, the staff probably aren't out there to employ.
Yeah.
If you're going to increase the hours you work by 30%, it's not like our staff sitting on their hands. You need 30% more staff. We can't even employ into the substantive headcount we have for the hours we work now. Sarah's team's just done a bit of work. We look at senior grades, consultant staff grades, senior clinical fellows. We've got 101.6 full-time equivalent gaps, and that's despite more effort in this health board to recruit any way possibly than pretty much anywhere else I've ever worked. So increasing workforce just is a bit pie in the sky at the moment.
Well, they're not out there, are they? Helen?
Thanks. Obviously a huge problem. I just wonder, do we have any comparative data with other health boards, sort of their throughput, to know whether there's a difference between ours and other health boards, or to prove, as James already said, we're very short on consultants, and that's the sort of mismatch as to why we're having difficulty in getting the numbers through that Welsh Government seem to expect?
Yeah, so I think there's some level of comparison, but there's more I'd like to get underneath, particularly in terms of referrals, because we've seen that 20% increase in. Is that something that's seen across the patch? There's comparisons on things like treat and turn. There's comparisons around, but in terms of demand per head of population or activity you're seeing for your workforce you've got, it would be quite useful to have more of that. I think we are an outlier because where our position has deteriorated or is held in this position, others have been improving on the outpatients, and Swansea Bay in particular have eliminated more or less all the 52-week outpatients, albeit they've had a fairly chunky investment for planned care that we haven't had. But that's not to say, I know they've done a lot of work around treat and turn and some of the efficiency, so quite again keen to look at areas where they have made progress to see if there's anything they're doing that we haven't already picked up on, just to do that constant kind of test around Wales, because different health boards will have made progress at different parts of the system. The same with us, and so that's something we will be following up. But there's nothing obvious that's jumped out at us at this point that says we are not doing that. And yeah, and what from our own metrics, and there's some information in the appendix, is since pre-COVID we are doing more activity through core. So if you take orthopaedics, they're doing more through core than they've ever done. So that's a really positive step on efficiency. And we are continuing to increase, particularly outpatient, the total numbers for land treatments, which has got a cost risk to us that we've talked about before. ENT's a little bit different. We're doing a lot less on ENT and max facts. We know some of that is a consequence of the Grange model because of the cover we need. So again, they are areas we will delve into in a bit more detail. I know they also been working. Right, they've been looking at Royal College templates and have been making sure they adjust their patients per clinic in line with Royal College templates. So we've lost. So there's a combination of factors, and that's why we want to do the deep dive by specialty, so we can always bring back, because each specialty will have a different challenge and a different solution. Yes, that we need to work through. And again, we can almost compare at that specialty level. And I know, Leanne, you have talked about whether we can reach out to some health boards where they've made progress in some specialties and ask them to come in and work with us to see what other opportunity.
You must do a peer review type.
Peer review approach. So, we absolutely want to deliver these targets. I know they're being set with milestones. It's absolutely what we want. We don't want people waiting 52 weeks or 2 years for anything, but we've got to be pragmatic about what we can deliver over what period of time with the resources we've got.
Thank you, Hannah, and then Paul.
Yeah, just to build on that in terms of comparative, in some of these specialties, they'll have had GIRF reviews as well, which has got standards and analysis around opportunity for ourselves that we're picking those up. In Wales, we've got 7 clinical implementation networks, SINs, as they're being called, that are largely in these specialty areas as well, which are produced. They've been quite heavily leaned upon by the centre in terms of advice, whether it be online and news or some of the standards and ratios in terms of new to follow up, etc. So there'll be some stuff emerging through that work as well. And then just picking up some of the theme of the conversation in terms of learning, we had was it last Friday or the Friday before, Leanne, a joint workshop with planners, ops and Welsh Government, going through all of those 5 thematic areas and a bit of a sort of show and tell, or, so drawing Swansea in, how did you do that, make that progress in terms of 52 outpatients? I think it's fair to say AB was called quite a few times to explain how we've done so well on SOS and PIFU, and how have you, in some of our treat and turn rates and some specialties. So some of that is there, but I think there's still more to do to make sure that learning spreads.
Yeah. Well, there was a great emphasis this morning on learning, which everybody endorsed. Yeah.
I mean, I think milestones are really helpful. What we don't want is things to become millstones and barriers. And I think it's important that we, for example, I want to unpick the point that Nicola made, and the allocation of funding. I mean, we would expect, I think, or hope that funding would be allocated on a fair, rational, some sort of formula, some sort of criteria led. So why is it that we are a larger health board and yet we got less funding than another health board? I mean, do you want just sort of, and then to be held to account, well, they're doing wonderful. Well, they would if they were given £20 million extra and we got 2 or whatever the funding was. You're thinking actually we should be on a level playing field really, so that we could all be, you know, sort of assessed fairly, rather than saying, well, give me a shed load of money, you know, but that's not mentioned, and then we held to account because we get less money, and I just find that difficult to understand.
Yeah, I think so. When there was £170 million allocated out a number of years ago, which was for planned care, but also urgent emergency care and cancer. And then 50 million of ours, and that came up pretty much on a fair share basis. Then 50 million was top sliced, particularly to target the planned care priorities last year, which, you know, so we all took the hit and we gave that back on a fair share. There was an approach last year, which I kind of accept, which was we are going to use the money to target those longest waiters. So where, you know, that might be disproportionate, it might not feel like the right incentive, but I think we all agree we need to equalise the position across Wales. So that money was targeted into some of the health boards that had some of the longest waits. However, that money seems to have come out now more on a recurrent basis, using some of the information that was provided for schemes last year, which has disadvantaged us as a health board. We've had about 8% of the funding where we normally get 19%-ish. So it's about 5 million short of what we gave up as the top slice. So we gave up 9, we've had 4 back. And in fact, it's 2.5 million less than we had last year. So we'd even short. So I have shared the feedback with Welsh Government. They do acknowledge our position, but at this point in time, haven't got extra funding to allocate us out. But you know, I will be formally writing to Welsh Government, particularly now in the context of our position has deteriorated on some of the outpatient side of things in particular, and the focus and the expectation on us around planned care. I think more than ever, it's really important that we get an equal chance of addressing that.
Follow up then, yeah. Thank you.
Any further? Yes,
it's just really around being pragmatic and realistic about our ability to meet the targets. And you know, we've already mentioned money, but money doesn't cure everything. Staff issues, but also I think the other thing is, do we actually have the physical space to be able to treat people? If you did have the clinicians, etc., I'm assuming that we wouldn't actually have the physical space to treat people more quickly if we had more money and more doctors, as it were. I know they're not just doctors, but so how do we? I guess my question around that is, given that it doesn't appear to be terribly realistic or practical, some of these targets, how do we feed that back that we don't have, you know, the money, the people, the space, the equipment, whatever it happens to be, that is causing a barrier to us actually achieving? And aspirational, great, but I'm trying to be practical.
I think you've made a couple of really important points, Pippa. If I could just pick up on the first one. So I think the well-being of our staff, asking our staff to do lots of additional activity, is a stretch in such, I think, challenged operational circumstances. So I think we've got to be mindful of that, and certainly in some of my engagement with the clinical teams around this latest request, staff wellbeing has come up as a particular issue. So we do absolutely need to be mindful of not asking people to place them under yet more pressure than they're already experiencing. We do have space, you know, the fallow lists, I guess, sort of potentially could come into mix. We know that outpatient, Paul's been helping us with a really important piece of work around a room booking system for outpatients. I think we've talked about here before. So we know that there is a state that we can use for some of this, and some of it doesn't necessarily require physical estate in terms of things like virtual review and those sorts of models. So I think we do have, I guess the choices that we're looking at are being tested from a feasibility perspective. But I think the really important point I just want to tease out is that we really need to do this in a sustainable way. We historically, as a health board, have chosen or opted to undertake this activity in a non-recurrent, pretty expensive way. We've had the ability to turn it on and off. That's been to the advantage of some of the clinical teams as well as the organisation too. But incentivising the teams to transform the service, put in place different pathways, is really much more challenged when we're doing sort of ad hoc, potentially expensive activity. So there's a balance. We know sustainability is probably definitely the kindest kindest offer for our staff. It'll take us a little bit longer, but equally, we've talked about the financial pressures we've got. We can't burn money. We haven't got that money to spend. We've got to spend it wisely. And I think the sustainability option for us and why the deep dives. And I'm very clear about what we can and can't do, risk assessment of that. And I think, you know, all of the conversation for confidence that we're having as an executive team, and we'll have in more detail tomorrow, because the teams, as I've said, have been working until midnight to review the plans off the back of revised targets from Welsh Government. I don't think the exec team would support plans being submitted that are undeliverable.
The board certainly would. So it's a bit gloomy, but we've got to get under the figures, given the workforce and given the capacity, so that we get an absolutely definitive view of what we can do and what we can't do, and what the quality is going to look like, and where we're productive and where we're not productive. How sustainable are some of the services, because some of them are quite small, aren't they? And the number coming through the door are escalating, and that's really the compounding problem. So I think, you know, do keep the board informed of these reviews as we're going through, so that we can take expeditious decisions with you. Because this will remain a very potent topic of discussion over the next year, I imagine. Okay, thank you. Progress on the nursing, midwifery and SCPHN workforce strategy, please. Welcome, Linda.
To Linda and just
okay,
interest in time. But thank you, and thank you for providing an opportunity to share progress against the 2024 priorities set out in the nursing midwifery pathway. The board will probably, I'm sure, remember back in May last year, we brought with us to board the nursing and midwifery workforce plan, and it was ratified at that point. But there was also a promise we'd come back a year later to give an update against the priorities set within the action plan. I don't intend going through every action within it. It would take me some time, but I would like to pull out some pertinent actions that I think we're particularly proud of. And just prior to going through the priorities, I just wish to give recognition to our workforce and OD colleagues who we've worked in very close collaboration in order to succeed and achieve the outcomes set out. So if I just pick out some of the ones I think we're particularly proud of. So we intended to recruit 75 internationally trained nurses within the strategy, which we've done so, and we're on track to deliver the same for 2025. We could always recruit more, but we felt that that was an appropriate number in order to be able to provide the pastoral, but also the education support. Our international educated nurses actually attended a recent strategic nursing workforce meeting, whereby it was overwhelming with regards to the support that they're offered when they started in the many of them, quite rightly, now hold very senior positions within the health board, which they're so grateful for, but it's very, very well deserved. We've placed significant focus on our future nurse academy, and that's both for our registered and unregistered nursing workforce. We know that our healthcare support workers are the backbone of the health boards. It was extremely important that we place emphasis on their career progression. We've opened up opportunities for our healthcare support workers through supporting them through flexible routes into the nurse education if that's which they wish to do so. That has been done through universities, but we've also increased our open university capacity as well. And for the first time, we've actually managed to place 10 of our mental health healthcare support workers onto the OD route into nurse education and registration. We've also placed significant focus on our advanced practice within ABHB for our AMP, CNSs and our consultant nurses. As opposed to a substitute for a doctor, what we're now seeing is nurses working in advanced practice, leading and supporting services within ABHB. We now have consultant nurses in dermatology, respiratory, frailty, bladder and bowel, CAMS, maternity, urgent care, and we also have them in heart failure and cardiac rehab. And we're also looking to progress the consultant nurse post within mental health. So I think we can see that we're making significant progress there. Within the consultant nurse team, we are also very aware there's a huge amount of expertise there. And from that, we've now developed a strategic group which will drive and shape advanced practice within ABHB. We're only Health Board in Wales who are actually working in collaboration with HIW and Cardiff and Vale University and the RCN to progress the RCN Connect student pathway. And that's for nurses, well, it's not for nurses, actually it's for individuals who have applied to do their nurse registration course. However, they've not been successful at interview, but have showed real aptitude for the profession. So we're working with HIW, the universities and RCN to bring them to us as healthcare support workers. But we're also supporting them through an educational programme with Cardiff and Vale in order to put them in the best position possible to be able to access the nurse education. Something which I think I must say I'm extremely proud of is the overwhelming success of the Nursing and Midwifery Leadership Academy. Gosh, I'm so sorry. For those who've been involved, I think I'm so sorry. You're all right. Anyway, I feel like that. The feedback of the course has been fairly phenomenal. We've seen many of these individuals move into very senior positions within the organisation. It's led us to develop onto additional leadership programmes such as our Lead 6, and we've also further developed our Journey of Excellence for Band 5s. Our engagement with local communities significantly improved. We've got presence at schools, colleges, job centres, really highlighting the future of nursing and entering to highlighting and nurse as a future career. We've improved our branding and advertising our posts by social media. And lastly, I just want to mention, and I can't take any credit for this, is around the retention, thank you, of our staff. And that's work that's been undertaken by Sarah's team, which Helen Knight has led on. We can do as much work around recruitment as we like, but if we don't retain our existing staff, there's no point. So just some of the outcomes I just would like to share with you. I can't say it's all down to the strategy, but I'd like to think it is. We've seen a significant reduction in our RN vacancies since April 23. We've reduced our RN vacancies by 70 whole-time equivalents in the last 12 months. Our healthcare support vacancies have reduced by around 50%, and we're currently in the process of just validating that with the divisions. Our turnover is reduced from 8.31 22-23 to 7.66 in 23-24. We've seen a fairly marked reduction in our sickness for both registered nurses and healthcare support workers. However, I need to take in mind some of the figures will potentially be skewed by the COVID pandemic, but we have seen a significant reduction. And lastly, I think this has probably been discussed previously, but we have seen a significant reduction in our variable pay. Sometime, it wasn't that long ago, we were in excess of using 250 full-time equivalent agency healthcare support workers. We've eradicated healthcare support worker agency in all divisions other than mental health and community. There's focused work on reducing that further. We've also significantly reduced our off-contract agency, where previously we were using around 35 full-time equivalents. We're now using less than one whole-time equivalent consistently. And just lastly to say, the priorities for 24-25 have been set, which is you'll see within the pack, which now will be handed over to Jenny and Kelly, hopefully to come back next year and update you on further progress. Thank you. Sorry for being so.
Thank you very much indeed. That's really helpful, Linda. Are there any questions to Linda?
I just want to say a huge thank you as Linda enters a new job. You know, none of this, the nursing strategy we approved, the nursing workforce strategy, we couldn't have done without Linda. You know, she's really led this from the top, been very passionate about it. And it's introduced real change. You know, we are, you know, if you just look at our international nurses, when Linda Jones went to India, people were saying we want to work in AB because we're so supportive, because we've, you've supported our family members. We've got family members coming over now. It's those small things that make a huge difference. But we couldn't do it without Sarah's team as well. And it really is a joint piece of work.
Thank you. And thank you very much, Linda, because you've done an excellent job. And I know you're back with us, but you are supposed to retire.
I'm usually a tough Scottish girl.
Not at all.
I'm working it hard.
Working it hard. No, it's really an excellent piece of pragmatic work, because it's working, isn't it?
Thank you.
Not just pie in the sky. Nicola?
No, yeah, I just wanted to echo what you and Jen have said, and also just that bit about the academy, the nursing academy. It really is quite a special programme, I think, isn't it? You're on the third cohort.
I think we've just moved on to introducing our fifth
cohort, and it's when you get to see some of the impact of that, it really is a celebration and the development it gives the nursing. Future leaders of nursing, that's really something, and I know you've been a huge, a big influence in that. So thank you from me as well. I'm not going to.
I would have said more about playing this.
No. Excellent. Thank you very much.
Thank you.
Oh, it's nice to hear success, isn't it? Right. IPFR then, James.
Craig from the Sublime. So IPFR stands for the Individual Patient Funding Requests. We spoke earlier on about multiple sclerosis and the service changes they're affecting very large numbers of people. So the IPFR process is absolutely the other end of the spectrum for single patients with complex problems that aren't normally funded as part of commissioned activity. This is the process that supports access to care for these patients. The citizen can access care through IPFR processes organised by ourselves for things that are commissioned by health boards, and through WISC for things that are centrally commissioned. The paper sets out the decision-making process that we follow in line with the All Wales guidelines. The process itself is subject to significant external scrutiny. There's a peer-led quality assurance group who keep an eye on our activity, and there's annual training for people who participate in IPFR decision making to ensure consistency of decision making. Having experienced an analogous service in England, the process in Wales is much better, and it is much more joined up. And the IPFR decisions that we make feed into an All Wales database. And if they see that IPFRs are coming through for disease areas or treatment areas, they use that to drive development of national policy, either through the All Wales Medicines Group or through HTW. It is a very important underpinning process to our INU process. So INUs are interventions not normally undertaken. They're a list of interventions that the NHS doesn't usually provide, but in medicine, as in many other areas, you can never say that something should never be done 100%. There's always exceptions, but the policing of those exceptions for consistency takes place through the IPFR route. You will see that we, generally speaking, pretty consistently approve between 70 and 80% of the applications to the IPFR group. And just to reiterate, the quality of that decision making is assessed externally and has been recognised to be of high quality. One of the anxieties, I suppose, I have as medical director with this budget assigned to me is that this is a growing area. So in 2019, our IPFR spend was about 200,000. It's now 723,000. There are within that sort of cost growth a very small number of patients on very expensive treatments, which are very closely scrutinised. But over £250,000 of that growth comes from just 2 individuals who would not be alive if they did not have that access to that treatment. And then the final thing covered within the paper is the WISC declined an IPFR application, and that declining of care was taken to judicial review, and the finding was in favour of the plaintiff, and as a result, IPFR processes were reviewed across Wales. In fact, we didn't have to make any changes as our processes were already compliant, but the judicial recommendations mainly centred around timeliness of decision making and documentation of decision making. So the paper's brought to you to provide assurance that we're following the All Wales processes, and I'm happy to take any questions.
Thank you, James. We did ask for this information because it's not generally something that we consider in any yet. And it can be so important to the individuals concerned. Are there any questions to James about this?
Can I just ask one?
Yeah.
So does a clinician have to refer the patient to you, the case, or can they apply?
No,
How does it work?
needs to come via a clinician. So the usual thing is usually and the beginning part of the paper, you'll see there's a set of evidence that they need to provide, and then that is reviewed by a multidisciplinary group who decide whether they feel that the expenditure is justified. And the key thing is that the funding isn't open-ended, so there's always a review period set, and that review period is the shortest possible time in which a benefit can be shown. And if there's no benefit from the treatment, it's not continued. It's a whole panoply of things. It will be drugs that have been shown to have benefit in a particular disease area but aren't licensed in that disease area. That's probably the commonest medicines one. And one other example from this year was a child with a very particularly rare neuromuscular disorder who required a bespoke walking frame made for them, but to allow them to walk, because the standard ones wouldn't allow them to be mobile. So it's a really good process. The good thing in Wales that it's not a capped amount. In England, there's a fund, and once it's spent, patients don't get the care. So it's a relatively small amount of money, but it's really well administered in Wales.
Okay, but it's only referred through. So I know it's through clinician, but nobody else.
No, you couldn't stop.
No, that's great. Yeah, it's great service, isn't it?
Yeah, I think it's super.
Fantastic.
Thank you, thanks, Penny. Any further comments? Thank you for that work, and it's very reassuring to know that we haven't had to change our policy because we've got it.
Good.
Right.
So Anne-Marie, who leads the health board, actually sits on the national group. So.
Yes, quite. Moving on, the communications and engagement update report, Nicola, please.
Yeah, thank you. And Karen Newman is on the call, who's my Assistant Director of Communication and Engagement, who you know well. So this is an annual report just to keep the board brief on the range of activities across the health board around communication engagement. The report is fairly self-explanatory, but I'll just highlight a couple of highlights from the past 12 months. So we refreshed the communication engagement strategy during 23-24, and really the comms engagement team continuously looking at innovative approaches. I know we've been talking about some of them to make sure we can connect as much as possible to our staff and populations. As mentioned in the report, we've refreshed the staff engagement and communication plan to make sure we reach in staff. We've looked at our branding, online communications, drop-ins, and continuously keeping that under review. Targeting our younger audience, as we mentioned, and we've had a good debate about TikTok, but constantly looking at how we can reach some of those parts of the population who possibly don't always engage. There's been a huge amount of activity around the public health and prevention agenda in terms of continuing to take the opportunities of that. And again, it's a fine constant balance between responding to areas of public interest, negative reports and promoting lots of the positive work we do, and the team work really hard, and we've got a huge reach around our social media, and if you compare it to other health boards, we've got a huge number of social media followers, which is really positive when you need to get a message out, but it brings its own challenges, because we all know social media can be a platform for people to share their views, which is good, but maintaining that kind of two-way feedback, and Karen and the team work exceptionally hard managing our social media accounts on a daily, nightly basis, and I really just want to give recognition for that. The 24-25 priorities, the team are supporting the 10-year strategy work to make sure we get wide reach, and I know Karen and the team are looking at how we continuously strengthen that community engagement offer, and the teams, you know, we obviously pulled that back through COVID, but the teams are out and about in different locations every week, and again trying to get broad coverage of the populations as much as possible. So there's the detailed annual report is there with some of the statistics as well. And I just want to personally thank Karen and her team for the exceptional work they do around this agenda, which can be very rewarding and challenging all at the same time. So thank you.
Thank you. Pippa, and then
I've got a few points. I will try and wrap them all up together. First of all, I think I mean it's really interesting that there are so many social media followers, but just because you've got people who follow you doesn't mean they read anything at all that you write. And I think we should be very aware of the fact that we can be quite reliant on the thought that social media is doing everything we need it to do. I actually followed a link from an article in Wales Online recently, and it wanted to take me to a Facebook page. And knowing several people who don't even have a Facebook account, I thought that was something that we should try and make sure that we do. If we're providing links to external organisations, it should be to somewhere where everybody can access. I also wondered, I noticed that it's been 175 or more than 175 venues that have been visited in the past year, which sounds great, but we're not receiving, I don't think we receive anything at board like the kind of CLICE report that says we've been out and we've spoken to people and they've told us this. And I'm not certain that we see that as a board. And I think that would be particularly useful. The other thing, I think it's great that the exec are more visible because they're getting out and about, but it's reported in there that it's only 2 to 8 people per visit. So is there a way we can do that where it's more cost effective for time, so that perhaps the exec could be available on a Teams link or something rather than being in person, just because it cuts down on travelling? And if it's only for 2 people, is that what's making the difference? And are we allowing access to the greatest number of people, or is it just the people who are in this venue and happen to have a break, as opposed to somebody perhaps being able to access you, you know, because you're going to have Teams on in the corner of your room for 2 hours and they can drop in and out off that. And finally, the Gwent Health Guide is, I thought I went onto it thinking it's going to link me through to the NHS Health A to Z, which lists all of the symptoms I could possibly have. If I'm going to try and use Dr. Google to diagnose why my big toe hurts, then my big toe doesn't hurt. I'll reassure you all. Sorry, but it's obviously the Health A to Z actually gives you an idea of, you know, what you might look for with your symptoms. But I found when I went onto the Gwent Health Guide that despite the front page looking like it's going to be really, really useful to me, it connects me to quite a lot of links with phone numbers and websites and those kinds of things. And I didn't think it was the easiest to navigate compared to some of the NHS, the UK-wide NHS advice on whatever it happens to be. And so I wondered if there was a way that we could link that into that page as well. I'm not saying the websites and phone numbers and things aren't useful, because of course they are, but it's about how can we maximise the opportunity for people to be able to use that. And at the moment, I think it's more limited. And so that's my 6 points, I think. Sorry, yeah, I had a list.
Thanks, Pippa. I'll pass to Karen on one or two of those, just to pick up the point around the venues. So I know there's a weekly kind of update on comms that comes out and picks out the themes, but I think Karen and I have spoken about how we get a bit more formal reporting around what people are telling us through the meetings, through the venues. The whole drop-ins is something we keep in under review. Some, you know, there's a mixed response. We've been considering trying to match it with a visit. So you might say, well, I'm going to do a drop in the Liverpool for an hour and then I'm going for a visit to the pharmacy team there or something. So we're trying to make use of it because, and I think we're trying to work out if the more we do it, you get less people interested or more people get to know about it. But there's something about giving people the opportunity and the visibility. And obviously I think I've done 3 or 4 now of the online communication. So we've had about the last probably between 50 and 200 people join those, but we've recorded and put it on the intranet. So if you can't, lots of people can't make it because they're busy doing their clinical work, so at least they can watch it later. And Paul, for example, he did a session on digital at the last one, so it isn't just me talking all the time, and we've looked at how we, and again, trying to get feedback from staff about, is it helpful? What other things would you like to be? So it's a bit of work in progress, and I think we will probably after the 12 months say if the drop-in's working, how can we refine them? We need to constantly look and listen and refine. But it is about trying, because there's always been chief executive drop-ins, and I carry on doing those, but you can get much greater reach if and it's important for the other execs to have. And I'll Paul, you've had a couple of people might come and talk to you about workforce, and some people coming, particularly because James is the one that's done the drop-in, because I want to talk about a medical staff issue. So it does give, but it is about keeping, when it's 1 hour a month of each exec, it's not eventually time consuming. It gives us a chance to be on another site, and going up and talking to people. So, but we keep it under review because, they're important points and we need to make sure we're effective with what we're doing. I don't know if Karen wants to come in on the health guide and the social media links.
Yeah, that's okay. Yes, please. Totally appreciate what you say, Pippa, on the social media, because it's okay to have, probably the biggest following in Wales on our social media, but unless we're engaging with them, unless they're finding the content useful and coming back with us, it's no point. But what we have got, so for example, we've got over 1.2 million reactions to our posts. So what we know is, and we've had over 30,000 comments and engagements. So people are constantly contacting us every day through our inbox, talking to us, asking us questions, asking for support, commenting on some of the things. And it's another way really of where we are engaging directly with them, apart from in the community. But we constantly have it under review, as Nicola says, with everything else to make sure. And it's not the only way. Social media is one part of what we need to do, because rightly so, not everyone has social media accounts. So, working with our stakeholders, the press, all the others that we do to get the information out there on our website, posters out in our communities, on buses. It's everywhere and everything that we can do. And obviously we constantly try to look to do more. Gwent Health Guide, I really appreciate that feedback. What we tried to do was put everything in one place, because there were so many comments, because you're right, there's so many good websites, there's so many good apps out there. So we tried to put it into one place so people could go there and find it. But I would really appreciate having a conversation with you separately about your thoughts on maybe how we could get it better, because your idea is to try and make it easy for the public. And if it's not, we did test it with some of our patient groups, and we've tested in our communities and have refined it from there. But would be grateful of that if that's okay.
Yeah, that'd be absolutely great. I'd be very happy to do that.
Thank you.
Yeah. Paul, and then
you want to just to say, if you compare the communications and engagement with this organisation with others, I think we are in an incredibly strong place. I think the quality of the information provided, and certainly looking at the evidence and the data, I think is incredibly impressive. And I think that what I've been impressed about is the reach in terms of sort of the groups, looking at the councils, the 5 areas, links with schools, the staff, the internal staff. And I think, it's all about continually self-improving. And as 1 year goes by, a new year may have different challenges. And I think that's what Nicola was saying, really. Things that have happened this year may change next year. And I think there's a flexibility there. But I did want to say to Karen and the team, I think you're doing a fabulous job in terms of the work that you have been involved with. And it may be useful to benchmark against some of the other health boards to see where we are compared to other places, really. But
Please.
I just wanted, thank you, Karen, for the report. I just wanted to ask the CEO questions. We've got what the top themes are, but nobody ever says what we've actually done about them. Because these 3 themes, as from a trade union perspective, are high on everybody's agenda, especially the parking and being part of the EDI team temporarily. The disability parking is a massive issue. And I just wondered whether or not next time we do a report, we can actually say what we've done about it. Or are we just saying we'll listen to you, but we haven't actually done anything about it. So it would be interesting to know what we've actually done about it.
You know, absolutely. And we did, it was kind of a half joke, but we did talk about the next online communications is asking Jamie to come along as the divisional director, and together me and him cover those real topical issues that the staff are interested in, like the car park, the restaurant provision, security. You know, they are the things that people they are that really interested in. So we had a useful divisional review with facilities and estates this week, and with some of those issues as key priorities that we will be discussing as executive team. So some things we respond to, and I think you're right how we do that two-way communication, and others about things that we are planning to address, car parking in particular, in terms of what we can do differently across the sites. So we probably do more targeted communication on it, but we also haven't got all of those issues sorted yet. But as we do make progress this year, we can having that more formal communication back.
No, I appreciate that. It would just be nice to see these are the top themes and these are some of the things that we've done. Actually, we've listened to staff and we're trying to address them rather than say what the themes are. Yeah,
it's really important.
We did.
Yeah, you said we did.
Yeah, absolutely. Yeah. Would be useful. They still continue to be, and some things I would say we've addressed, and other things we are ongoing. You know,
we all know that they'll come back. We all know that they'll come back time and time again, but we still got to try and address.
Absolutely, yeah. And they're the things you pick up. Thank you. It's helpful.
Yeah, just on Pippa's point, really. When I did the visit to County, we arranged a walk around afterwards across the whole site, and I picked up a huge amount of feedback, suggestions, which obviously passed on to the communications team. I think the important thing is kind of the point that Louise made is, so what I think it's really important to provide feedback on all the comments that we get and suggestions, even if we can't do them because we don't have the resources. I think providing that feedback, the staff will encourage more people to come forward.
And I think that's kind of partly what I was trying to get to, and I think Louise actually probably put it better than you thinking about staff particularly. But I was thinking about, you know, all of these sessions that we do when we get the information from the public, then I think as a board it's important for us to understand what people are talking about, and then what are we doing about it, so that we understand the impact of the communications team. But I think the combining it with a visit is not something that comes across strongly when I see it on. I just assumed that you went somewhere and you sat and waited for people to turn up, and so that, you know, it's interesting to hear how they're being conducted. So
I think you may be worth us maybe a 6-month report, which kind of picks up the feedback loop around Ask the Chief Exec of their new visits and the drop-ins, because we've got a feedback form we take with us as well now to make sure we collect the feedback, and we are trying to systemize responses, so we don't just say, well, that was interesting to you, but we're cracking on with, you know, there is that feedback loop.
I was just saying to Anne as well, I think there's a role of People and Culture Committee and to having that focus, so we can build that into the work plan.
I am aware that staff do like the drop-ins. It's just having the capacity of your clinical. Yeah, quite. At least and most clinicians that are on a template will need that 6 weeks advanced warning to be able to be, you know, to leave their post, to be able to come and speak to anybody. So we've got to take all that into consideration, that people have got those opportunities. Because once you template it in, it's very difficult to turn around and say, I want to go and see the Chief Exec and ask her a question, but I'm not going to see Mrs. Jones. So the answer is going to be no, you can't. Yeah. So, which rightly so. So, you know.
I think it's also important that if you're going out to venues, etc., and you've said, we're listening to what the public say about the way in which they want to receive and share information. So what did we change? You know, it's that, the consequence of the engagement. I think we need to make clearer, be helpful. Hannah?
Yes, just a couple of points. On my last one about the public engagement, it's just to say those, you'll know from the strategy work, we're doing some bespoke strategy sessions, but we are still working with Karen's team on their broader conversations and making sure all of those themes, because we already have loads of insight and rich information on concerns and views that we just need to make sure we do more generally. On the exec drop-in piece, just I think it's important we review it in the context of a sort of a suite of things to make us more visible and engaged, exec drop-in, Nicola's sessions and other activities, recognising that, as you said, Louise, staff work in a different way, some work on templates. Where I found it very, well, if they're all insightful, but, you know, staff members who don't have a PC or email address, so they'll never go on one of those Teams sessions, and the fact they've seen particularly a lot of our FM staff, so they, you know, popped out of the kitchen and they would never have had the opportunity to engage in some of the other mechanisms because they just don't have that, as I said, email or capacity. There's one PC in the whole of the kitchen area. So it's important we see it as a range of things. Yes.
Fine, thank you. Okay, thank you very much, Karen, for that.
Thank you.
Moving on to the strategic risk report.
Yeah, thank you, Chair. So the general update, you will see that we've amended the strategic risk register for the changes that we approved at the last board meeting. Of the risks that we've now got, there's only, as a result of the committees and the review of the register, there's this one proposal to reduce the scoring, the risk score of the risk relating to the threat of industrial action as a result of the current negotiations underway, recognising, you know, there is still a risk, but at the minute it's being reduced. So that's the only change that is being proposed to the risk register. It's worth just continuing to note there's 8 high-level strategic risks, and of the 6 of them are managed outside of our risk appetite, and I would say we've got plans in place where we are, you know, heavily involved in work to scores. So that was all I was going to say, is just happy to ask for the board to approve the change in the risk score for when and not the work we're doing around those areas where we're outside our appetite.
Yeah. Any comments on this risk register? I had a long discussion about it last time. Are we happy to endorse the recommendations? Thank you. The RPB update.
Thanks, Chair. So the paper just sets out some of the headlines around RPB activity. Just to note, since we last met as a board in March, the RPB hasn't met, but it's got a next meeting next week. So some of this, so there'll be some updates following that. So a number of areas in the report, just to pull out a few. The report sets out the background approach and current allocations around the further faster money, but building community capacity. The RPB did agree at the outset an approach to handle prioritisation and allocation in line with the themes of the sort of policy. How it's been deployed, as I said, is set out pages 3 to 4, and to note that the regional leadership group and the adult strategic partnership will oversee the delivery of those schemes that sit within the RPB, and reporting, whilst it's a separate line next up RIF, will deploy. There is a bespoke reporting, I should say, so alongside RIF reporting requirements, there'll be a bespoke one around this further faster monies, but we'll pull it together in terms of reporting up to RPB. The work to respond to the recommendations of the governance review continues via a task and finish group. Progress sort of inching forward in that respect. And at the last meeting, some work to look at the resourcing for the RPB. You'll know it's serviced by 2 teams, the PMO that we host and the partnership team that Torvine hosts. So some work to explore resources and combined resources in those teams. the challenge now is how we get those teams to work together smarter and more aligned. And I think that needs to be a focus. In its meeting next week, the RPB will be receiving a detailed report on the RIF expenditure and delivery against the RIF for last year, so 23-24. It's driven by significant requirements in terms of reporting, challenge for teams to sort of surface some of the key themes, enable colleagues to see the wood for the trees on that. So that will be going into next week's meeting. And just to note, in terms of this year and the allocation, I previously updated around an approach that's been agreed to do evaluations. That work has started. But obviously, we are in the year, so the indicative allocations and awards have been made, but they are subject to those, noting that the evaluations will continue, and with the prioritisation that's also set out within the paper. So that's all I was going to say, noting there's a meeting next week.
Everything, what a thrill. Any comments or questions on this? I think one of the more worrying discussions we had at the last meeting was the issue relating to the Care Collective, which was a large third sector organisation that declared it could not continue at very short notice. And I think that basically, as a consequence of that, we need a really good market analysis report of the third sector, and also need to really understand which third sector organisations we have and what we use them for, because there's a lot of concern being expressed about the fragility of the third sector. I know there is a wish to extend further funding over a longer period of time to the third sector, but I don't think that the RPB has a clear view of how fragile this sector is and what can be done best to support it. So at the RPB, I should be pushing for that. I think it's important we get a grip on it, and certainly not be left as we were in this instance, where another organisation had to fortunately come forward and pick up this really vital service. So I think we need to do something about that.
So Leanne, could I follow that up? Because I think that's probably replicated in lots of areas. And I think the issue is when you've got a fragile budgetary position with an organisation, particularly the health board, that have supported the voluntary sector through, thick and thin, really. Suddenly, when our budget's held to account and there's no sort of definite sort of knowledge of exactly where we're going to be, then that puts other budgets are fragile. And I'm just not sure what the answer is, but it may be the RPB with local authorities and the health board can get some sort of, I think you call it market analysis, but get that conversation going to see, well, because the budgets tend to be 12 monthly, 12 monthly, 12 monthly, and that causes problems for the voluntary sector with regard to are they going to make people redundant, or their planning, etc. But it needs a big conversation about longer term planning for the voluntary sector. Yeah, exactly. I'm not sure, Nicola, whether or how we engage with the voluntary sector on that basis, but I think it's really causing major problems for a lot of really good voluntary sector organisations.
I agree. I do think it needs a bit of a deep dive on that.
Yeah,
because there's a number of issues popping up, isn't there, in different places.
Oh yeah, and the membership organisations are very quite rightly concerned about this. So I'm meeting them in about 10 days' time to discuss the situation as the RPB chair.
And yeah, governance is another problem, another issue that's come to the highlighted through this, hasn't it? Because this was a surprise to everyone, wasn't it? There was nobody quite knew about it. So exactly. I think,
yes,
governance.
Yeah, no, that's another issue that we've got to tackle, about how it's a question of how were the contracts managed, what were the commissioning responsibilities on either side, and that needs all that needs sorted
because it's such a surprise.
Yeah. Because I think we had 2 weeks or 3 weeks notice. Very difficult. Okay, so we'll take that forward. Thank you. Thank you very much for that. Nicola, Executive Committee Chair report.
There's the kind of usual report. I'll just pull out one or two areas that we've noted. So we mentioned a few times today the under quality and safety of the learning from death report is, I think it's a really good report. It came from the executive commissioned and you know, it is important that we start pulling out some of our more mortality data alongside performance data. We measure time. I'll give two examples. So we know stroke, there's a lot more work we've got to do in terms of our performance and access to the stroke board. But since August, I think last year, our stroke mortality is significantly improved and is now one of the lowest mortality rates in Wales for stroke. So, you know, really good. And likewise, you know, we know we've got significant work to continue to do around the Grange ED, but again, the mortality rate for the ED department is way below the Welsh average. So again, suggests that in terms of how we manage clinical risk, notwithstanding, we've got to address the experience issues and the risk of long waiting. But, you know, it is useful to do those deep dives and then identify other areas where maybe we're an outlier that we need to do more work. And I know James is working hard with the teams, particularly making sure our coding is of good quality, but that kind of focus on mortality is really welcomed. I want to draw up the volunteering report, really good report produced with this one too. USOP, I think it is. And again, great work with the volunteers and that growing programme that is a real enhancement to our kind of workforce. And I know we are looking at how we can strengthen the volunteers into ED again to support patient experience while people are waiting. There's a whole range of items we discussed around maternity and neonatal care, an update on the Embrace report, the MAT-NEO programme, and really positive signs of improvement across the maternity and neonatal agenda. But one of the key themes that has come out quite strongly from all of those is that we haven't got a transitional care unit, and that is going to be a priority piece of work during this year, where we look at what the solutions are for us to consider a transitional care unit. So that's a key kind of priority that's come out of that work. And then just to finish off, as part of our...
Just explain what that is.
Yeah, so it's basically where mothers, they need to keep the babies in overnight and they're not really in a special care baby unit. They need to be kind of keeping mothers and babies apart when they need to be together. Yes. But the maternity board doesn't have the capacity to manage that kind of transitional care. That's an explanation.
Yeah, very good explanation.
Sometimes I talk like I really know these things. So yeah, so that's it. And then the last one is just in our system leadership group. We had a really positive session to looking at kind of innovation and looking at the future than just talking about the here and now. That was a really good presentation on the genomics partnership and showing the importance of genomics. And again, at the right point, I think precision medicine genomics would be a useful session for the board. Yeah, and some great innovation in radiology. We've done a really positive AI pilot around lung cancer diagnosis with chest x-rays, and also an alternative for basically using interventional radiology. I'm not sure what the GAE stands for now around surgery, but this is about using interventional radiology to help patients manage knee pain, particularly.
Molecular artery embolization.
Yeah, that's why I didn't know that's also. But again, I think we're the second in the UK to try this procedure and really are leading the way in some of the innovation. So it was a really positive session and one quite keen for the board to have insight into some of that kind of long-term board thinking and some of the opportunities innovation offers us.
Right, thank you. Good, we look forward to that, I'm sure. Questions to Nicola? No? Well, you're covering a huge amount of an agenda, I think. Yeah, the executive board. Hey, you're busy. 4:13. Sorry.
I think it's fair now to give the radiology team a shout out.
Yeah.
They've significantly recovered their operational position and they're also leading innovative work in a number of different areas. I don't quite know how they do it, but it's incredibly impressive.
Good. That's excellent. Yeah. Thank you. And they're quite very enthusiastic
They really are. We're extremely lucky, and that's probably why we employ the largest number of interventional radiologists in Wales.
No, it's good. I'll keep it up. Yeah. I did actually tell the minister about the lung cancer AI project this morning.
Yeah, I mean, it's really impressive. Yeah. And, you know, as a clinician, I'm now getting the AI-enabled chest X-rays side by side with a regular one, with a heat map on it that shows me where I should be looking. It's, you know, it really is a game changer.
It is worth drawing out because on average, a chest X-ray can take 30 to 40 days to report from a GP, 60 days sometimes through secondary care. And this identifies the high-risk patients within less than 4 days. But there was one example quoted that because the AI does the reporting, I think within 43 minutes of the GP sent the patient the X-ray, within 43 minutes of the X-ray, it came back as a high-risk lung cancer that was responded to.
The patient then went through into our RDC clinic, and they went from going to their GP with a cough to diagnosis in 3 days.
Right.
And, you know, that AI pulled 37-day wait out of the pathway.
Excellent.
No. So when we come back to you to spend money on bones and brains and other things for AI, absolutely, this is the
Excellent. Well, if it really adds value to the outcome of the patients, then it must be considered.
Yeah. And we're the first health board in the UK, as far as I'm aware, that has got a procurement framework for,
Good.
Certainly in the West.
Excellent. Thank you. Any questions? No? Key matters from committees of the board, including their annual reports. Anything from charitable funds?
Just to say, we are keen and anxious to spend charitable funds we have. So therefore, any opportunities any executive team member or divisional teams have for ideas to talk to the team. Or, for example, went around the county hospital and got in touch, and I said, well, Alison is a person to contact in terms of funding and securing funding, to go for it. So I think, let's share that information.
Yeah, because I think there are a lot of very senior staff who don't know about the charitable funds position, because I know certainly in Chepstow with their digital rooms, they didn't realise they could
I think
apply.
part of the work programme is about raising the profile.
Yeah.
There's real opportunities there
Good.
to do that.
Thank you. Finance and performance, Richard isn't here, but Ewan's on it. Is there anything particular, Ewan?
Nothing outside the report as you see it there.
Okay, thank you for that. Partnerships, population health and planning. As presented, I don't think there's anything further to add, except we've got a lot of work to do, particularly on the estate strategy, which we're eagerly awaiting. Audit risk and assurance, Ewan?
Again, nothing much to add to the report other than to say, obviously, that particular meeting wasn't quorate, but we have now caught up on the reports and the documents that we needed to approve.
Good, okay. And we've changed the membership, yeah. Okay, Patient Quality and Safety Outcomes Committee, Pippa.
Nothing to add to the report, but I would like to express my personal thanks to the whole team who supported, particularly Jenny, Peter and James. A huge amount of work goes in to supporting me in this committee, and I wanted to register my thanks.
Thank you. And MHAMC.
Likewise, Sarah Cadman should have a shout out for producing an excellent report for us, and I think should be acknowledged. And I want to thank Paul, who's done a huge amount of work on Power of Discharge Committee in the past year to bring it up to standards.
Thank you. Thank you very much, Pippa. Okay. An overview of Joint and Partnership Committee activity, the JCC.
Yeah, so this is the new Commission Committee, which met on the 9th of April, I think it was, to kind of just formalise from the governance perspective, and then held a special meeting on towards the end of April, particularly to cover off the EBITS issue.
Yeah.
So I'm just to highlight the yellow instead of. Yeah, so the meeting was held. There was a really thorough deep discussion as a result of all health boards meeting specifically about that item. And the recommendations were agreed. The 4 recommendations that we brought to this meeting were supported, but with 2 further recommendations added. One was around making sure there was a lessons learned exercise to be undertaken, and that there was a progress report would be produced on achievement of against the implementation plan milestones. So they were the 2 additional recommendations I'll set out in the paper. It wasn't unanimously supported, but there was sufficient support from the committee to progress as set out. And then there was a further meeting held yesterday on the more broader agenda, and felt it was very constructive and feels like it will be an effective approach going forward. Good.
Thank you. Any questions to Nicola about the JCC? No? Thank you. And shared services?
Yeah, so just a standard report which captures the key issues that were covered at the Joint Committee of the 21st of March. The shared services. Take any questions or comments on the issues?
Any comments on shared services? No? Thank you very much then. Any other business? If there is none, then the date of the next meeting will be on the 11th of July. And the main meeting is on the 17th of July, because we have to separate these because of time, with the annual reports and accounts will be taken first. Okay, we will now have a break of 5 minutes and then reconvene in committee, please. Thank you.